as that happens, I'm going to click record and just take it from there. 30 seconds. All right, 3, 2, 1. We are recording and live.
Good morning and welcome to day 2 of the Free2Care Virtual Conference. Yesterday we touched on interacting with hospital politics, the health and well-being of physicians, how to advocate for yourself politically, and then of course the efforts on mock litigation. And I hope that the undercurrent that you were able to get from that was that we're solutions based, and there's an undercurrent of hope, and that's really the key for why it is that we do what we do, because healthcare reform is pretty daunting, and many people have said this is just too big, and how on earth can we possibly make an impact? I'm only one person, and I'm not very important. I just do what I do on a daily basis, and I try to pay my bills and take care of my family. But I want to be able to encourage you through our sessions today to say, look, there are solutions, and that's the focus that we need to have. It's too easy to complain and to talk about the wrongs that are being done in our society and to ourselves, but it takes a good bit of effort and again, that undercurrent and underpinning of hope to say, I'm going to be a part of the solution. And so today we're going to talk about some solutions. We're going to talk about physician shortage. We're going to talk about rural healthcare, what's going on in the legislature and how you can get part of it. We're going to talk about the innovations that are currently in place in healthcare and that will be a part of the change in this industry that we all love. And then of course we're going to have some experts talk to us about drug pricing and what's going on there and how we can continue to make an impact there, because our coalition has just been at the forefront, thought leader in that piece of subject matter. But this first panel is a great group. You're going to enjoy it, and I think that this technology in this conference is a testament to how things can be done in the future. We have people from all over the country, and one of them in the country currently in a deer blind. So you'll get a great kick out of our panelists and what they'll have to say. This is a wonderful group. Enjoy today.
All right. Thanks, David. All right. I'm going to start off. I don't know if Brennan, you're going to do introduction?
Yeah, I'll give a quick overview on how to use Zoom for all the attendees out there. Each panel will be roughly 60 minutes, 50 minutes of discussion followed by 10 minutes of Q&A. Or also, Nikki, if you would like to, just in between just discussions and talk, check out the Q&A section. It's kind of how we did it yesterday, and have those questions kind of flow in the panel. That seemed to do well. And then at the hour mark, I'll just transfer everyone out, all the panelists, and bring in the new panelist. So pretty straight. Okay. And we can go from there. So Dr. Nicole Johnson, please, you have the floor.
All right. Hey, good morning, everybody. Thanks, Citizen Health, for sponsoring this event. It's very exciting to me to continue to be a part of Free2Care. My passion, one of my many passions, is to make sure that we are practically solving the physician shortage. As of right now, we know that there are projections that state that from the American Association of Medical Colleges, about 42,000 at minimum, up to 121,000 physicians will be needed by 2030. And that is assuming that all of the barriers to getting affordable and equitable and timely care have all been erased. Unfortunately, that's magical thinking at this current state, because we haven't really been solving the problem from a federal legislative end, or even a local and state agencies haven't really adopted real measures that are actually going to help fix these gaps. I mean, just an example, in Texas, 32 counties have no physicians at all. And 157 of all the 250 plus counties in Texas don't have an obstetrician, meaning women who are pregnant who have a way to get care during their pregnancy or even after the baby, during the time the baby is delivered, and they have to seek care outside of their own county. One of the biggest effects of the Affordable Care Act was to pave the way for states to allow non-physicians like advanced nurse practitioners or nurses to care for patients without the supervision of a physician. But and at this point, 24 states plus the Veterans Association administration has allowed a high volume of these practitioners in the workforce. But the data shows that these NPs are practicing in areas already covered by physicians. So the rural areas, our citizens are, to quote our Free2Care paper that we published back in April, they're the food, the fuel, and the fiber for our country. If we don't take care of people in these communities who are desperately relying on Medicaid and Medicare, we're going to lose a great, valuable resource to our nation. So today our panel is really going to focus on solving the care, the access to care, and the physician shortage, predominantly in rural areas, in rural communities, affecting all ethnicities, and the population that specifically has a high reliance on Medicaid and Medicare. So first, we're going to get Mr. Carl Schuessler in. He's a managing principal of Mitigate Partners and Benefit Strategies. He's a consultant for Medicare or medical care organizations, and he really described himself as being engaged in the pursuit of employer-built healthcare, which will replace the insurer-built healthcare system he affectionately calls the cartel. So he's going to start off giving us specific examples of a recovery project that actually helped a rural hospital. And then we're going to have Dr. Sheila Page talk about some solutions for improving the quality of rural medical delivery. Dr. Page is a board-certified neuromuscular medicine and osteopathic manipulative therapy physician. She currently serves as the president of the Texas chapter of the Association of American Physicians and Surgeons. She also served on the Texas Rural Health and Economic Development Advisory Council. And then finally, we're going to hear from Mr. Andy Mangione. He's passionate advocate for older Americans. He serves as the senior VP for Action Leadership team of the Association of Mature American Citizens, otherwise known as AMAC. Andy is going to discuss the Pro Bono Care Act of 2019 as a way to free your physicians and other practitioners to care for you when you cannot afford to pay. And then we'll kind of take questions as we go through this and questions as at the end. So Carl, take it away.
Thanks, Dr. Johnson. Let me share my screen. Brendan, let me know if it's going. Am I good, Brendan?
You're getting there. Yes, you're streaming now.
Okay, good. All right. Thanks, everybody. And I want to thank Citizens Health and David Blatt for having me here in the spirit of rural health care. I am slap in the middle of middle Georgia in a deer stand. This is kind of interrupting my hunting, but when David asked me to do it, I told him I was going to be in a deer stand. So we're right in the middle of the rut season down here. So first off, big day today. It's the world's largest outdoor party. I'm a Georgia Bulldog, and it's great to be a Gator hater. So we're playing the Gators today. And I just want to throw a couple of things with those tank top jort wearing Gators. It's been 1,099 days since the Gators have beat my Bulldogs. So just wanted to throw a little love out there. All right, let's get it rolling. So what we're going to talk about is building employer-built healthcare versus insurer-built healthcare. Do active management versus traditional passive management. I'm going to go into each of these. Relocalize care, the repersonalizing of healthcare. and then focus on building community-owned healthcare versus building the archaic insurer-owned healthcare. And really to maximize a local care team, the pharmacist, the physician, the hospital, and the patient. Back to Marcus Welby MD days, neighbors taking care of neighbors. And again, through active management, you can offer employees 10 times the benefits for half the cost, as you'll see in this case here. And there is a way for employers to have health insurance on their terms, their way. And that's what we were able to do here. If you don't get enough from this, you're welcome to go check this podcast out. The whole story of this hospital is in 40 minutes, 2 20-minute sessions. So check Christy Gupton's podcast out. I want to also thank the leadership at the hospital, Vince Sika, the CEO, who also is a Florida Gator, and he's actually in Jacksonville right now, Vince, so I apologize for that early stuff. Dan Hogan, CFO, and Lois Helton, HR Director. It's a state hospital district, 49-bed community hospital, about 220 employees. There are 157 employees on the plan. So let's kind of look through the challenges they were faced with. They're the 4th poorest county in Florida. This is in South Central Florida. Per capita income of $25,406. The BUCAs, when I say the BUCAs, that's Blue Cross, United, Cigna, Aetna, Humana. We're extracting millions from the community. So quickly, this is a slide I talk about a lot. Dr. Johnson referenced the cartel. Look at the top 20, Fortune 20 here, and look at the companies that are involved. And you'll notice that you'll see United Healthcare owns Optum. They're number 5, excuse me. CVS Caremark's getting acquired by Aetna, and Express Scripts getting acquired by Cigna. I don't know how the DOJ operates. I'm not a politician, but I sure don't get how they can allow that to happen. These people have extracted millions from Americans, and they've extracted millions from this county that we were working with this hospital. Passively managed risk. They were not actively managing their risk. They lost obstetrics in February of 18. Members have to drive an hour for deliveries. Anybody in the county has to drive an hour because they couldn't afford to have obstetrics anymore. And Nicole referenced that earlier. Foreign medical spend, that's all the spend going away from their hospital by their members, those 157 employees, the last 4 years was 79%. They don't do everything there, but that's an awful lot to leave. And their spend in medical and RX was about $2.2 million when we met them. And we got hired in August of 18. And here are some of the solutions we put in. Eliminate the middles. We implemented a program we built for the last 7 years called the Fair Cost Health Plan. Moved from the BUCAs, the insurance companies, administrative service model, to an independent TPA. So we eliminated all the middles, all the middle people, middleman. Active management eliminated passive management. Let me give you a quick rendition of what this is. Most employers use what we call, they hit the easy button. They're hiring an insurance company to manage their benefits and pay their claims, and they're processors is what they are. They process claims. They don't pay them. They process the claims with the employer's money and the employee's money. We call this BUCA Insurer Built. And when we met the hospital, they were a BUCA Insurer Built plan. It's passively managed. What we're talking about doing it is brick by brick, with the foundation being direct primary care. This is what we do. We sat there on October the 1st, 2018, from 1 in the afternoon to 6 in the evening with the team and some of our partners building this plan. And we call it employer built healthcare, brick by brick, picking the best bricks. So we deconstructed and rebuilt it. And that's what we call employer built healthcare. We relocalize care, getting back to neighborhood healthcare. The world is a big place. This is South Central Florida. By relocalizing care, you can build a community health plan. If you look at this little blue circle in the middle of that circle, we're talking about building the community. We're talking about growing the hospital, getting outreach to all the community and surrounding towns. Things like they do, Dr. Lee Gross will talk about in a minute, was able to coordinate a $25,000 knee replacement, bringing a surgeon in from Sarasota, Florida. The average going price in the surrounding counties could be up to $100,000. So that's what we were able to do there. And this is I'm gonna let y'all read this, but if you eliminate the counterproductive barriers inherent into traditional insurance, where you have insurance companies, pharmacy benefit managers, and all the people trying to manage the care of the patient, it gets very cumbersome. My father was a 40-year OBGYN right here in this town where I am, Macon, Georgia. And the insurance companies were just, it was awful for him to try to deal with them. He couldn't practice medicine. So we eliminate that hassle and get it back to local care where it's supposed to be. All right. We utilize a cost and quality transparency tool with direct cash pay. We were able to let these employees know how to get to the best provider, best physician at the right time, the right place, and lastly, right quality, and lastly, right price. And so we have a tool they all use. Here's what's really criminal to me that really frustrates me and everybody gets me going about the cartel. BUCAs know about provider cost and quality, yet they stand passively by and pay $40,000 for one knee, and 2 feet away from them, the other hospital's $135,000, and they're doing it with your money. And so what we're able to do with a hospital is we were able to fix that. We offer 10 times the benefits for half the cost. You're going to see in a minute. We weaponized the land, and the hospital became their own pharmacy benefit manager. For the audience out there, if y'all have ever heard of PBM, that's program bilking millions. Not anymore. We've done away with that. Let me give you a quick example of what I mean by this. This is the pharmaceutical shell game, the PBM shell game. And when I talked about the Fortune 500, many of these companies are in it. So I want you to look at this. Obviously, you can tell I'm sitting in a deer stand. I'm not the sharpest knife in the drawer, but I know there's a lot of money changing hands here. And this is how drugs are delivered to members in a health plan. Pretty confusing. So there are your manufacturers. There are your wholesalers. Every one of those was in the top 20 of the Fortune 500. And then your pharmacy benefit managers we just talked about. And those are the 3 biggies, and that's where they are. And then the pharmacies that deliver the drugs. What we've been able to do is got rid of the pharmacy benefit manager PBM, and we made the hospital their own PBM. And we've also had special arrangements with community pharmacies where the drug copays are less at community pharmacies. That was really important. Keep the dollars local. Here were some of the plan changes that we have effectively started January 1st. We have a rich plan, eliminates deductibles and co-insurance. People haven't seen no deductibles and no co-insurance in 30 years, folks. Low copays, no barriers to care. So they had 3 choices. They could go to DeSoto with no deductibles, no co-insurance. They could go to the friends and family hospitals we identified and had direct contracts with for a little bit out of pocket, but not a lot. And then if they want to go anywhere else, they want to go to the Mayo Clinic, they want to go to the Cleveland Clinic. Their program before did not allow them to do that. They can go anywhere in the country. If they want to come here to this deer stand and me to perform surgery, they can come here. It's covered. I don't hear any laughter out there. All right, we implemented direct primary care. This is Dr. Lee Gross, one of the top DPCs in the country, was right there when Trump signed the executive order in July. Lee is how I met, Dr. Gross is how I met David. His organization has been huge. So we have a hospital that has physicians employed, and they put in direct primary care. The hospital saw the foresight, and Dr. Gross brought us to the table, and that's how we were able to do this. And why DPC, I'm not going to spend much time. I think most everyone knows why. They offered this DPC to the employees for no cost. So they can see Dr. Gross 20 times a day if they want to. Now, he may hit me for saying that, but they can. And then we implemented some proprietary claim analytics to analyze the data, and we integrated coordinated care very quickly. We were with a BUCA. They were the BUCA for 5 or 6 years. We analyzed the data. We identified 66 people who had the following conditions. We put them into lifestyle management, active disease management, and chronic care management. We identified 66. Within 3 months on this platform, 31 more people were identified that the other BUCA never caught. That's what it means to get good data. Data's king that makes this happen. Results, we relocalized care. We got neighborhood health care. We saved them $150,000 in their stop loss. 58% savings on their fixed cost to run their health plan. Because fair costs and all the cost containment provisions and weaponizing the plan design, the stop loss carriers rewarded the hospital for that. Offered 10 times the benefits for half the cost, weaponizing the plan design. This is key, guys. We went to 62% of foreign medical spend from 79% last 4 years. That is huge. They had people come to their hospital that were employed there who had never had care in the hospital because they had a deductible before, and we made it easy. And by the way, this hospital is an excellent hospital. It's a 4-star CMS hospital. They also hired their first full-time surgeon in county history. Significant. And their renewal of their stop loss plan, they got a rate decrease. Second ever in the history of this insurance carrier who has been in business 40 years. And here's the savings. 1.2 million or 54%, 10 times the benefits for half the cost, as we said earlier. Real quick, just to see it looking, we started this in October, went to our fair cost program in January, and you can sort of see the results for yourself. They spent less than $1 million, folks, when they were spending 2.2. Red bar represents where they were, green is where we are today. So now what are we doing? We're taking it to the streets, in the words of the Doobie Brothers. We're going to the city, the county, and the school, and the medium large employers. We've been talking with the city and county school for almost a year. We're finally getting traction, and we're trying to bring them together to offer the same plan to them and build a community health plan and keep the dollars local. We also have a very large employer that's talking to us as well. So again, this is the hospital. I appreciate your time, and if anybody has any questions, I'm glad to help. But guys, it is absolutely possible. You can't solve the problems with the same thinking we used when we created them. Got to make a change. And I just want to thank the hospital leadership and for the foresight to do a lot of these programs. And I think it's been a great win-win for everybody, and would love to help any rural healthcare system out there. It absolutely is possible. Thank you.
Thank you, Carl. Marion Mass, actually, Dr. Mass asked a couple of questions that were specifically directed to you, but she put them in the chat, so I'm gonna actually read them. Just a reminder for everybody to please put your questions in the Q&A section, not the chat. And for everyone who is not speaking, if you're not automatically muted, please mute so that your background is not interfering with the conference. Marion's first question, Carl, is it a plan for only hospital employees? Are there a significant number of DPC practices in the area where you did this? And if you tried this in a county without DPC, would it be possible?
All right, Dr. Johnson, I'm gonna do my best. I'm a little slow, so let me see if I can try to get that. So is this just for the hospital employees? This particular program was built for the hospital, but we're now taking it to the city, county, and schools where they can also put in a program like this and be in this organization. They could do what's called a captive potentially, but yes, it's all the self-funded employers. As far as direct primary care, this hospital situs in one county, obviously DeSoto County, and the direct primary care practice of Lee Gross and Dr. Crouch is right there on the premises. As far as expanding it, or when you get a hospital that may have 3 or 4 locations, that's where direct primary care can be challenging, but there's a lot of ways of connectivity, and it can work if you don't have DPC in another place. You just have to have different plan designs. Then what was the third question?
The third question is, if you tried it in a county without DPC, would it be possible?
Yeah, it would be possible, absolutely. But I'm gonna say this: I'm such a huge proponent of direct primary care. There's so many great physicians out there. I mean, I watched my father 40 years in practicing obstetrics and gynecology, and there's nothing like having a doctor that you can have a personal relationship the way it used to be before, you know, the early 90s when managed care came and ruined it. So it will work without it. I think it's a key building block, but we have other plans, Dr. Johnson, all over the country that don't have DPC, but we're trying to get it in all of them.
Okay. And Dr. Mass has a couple of more questions too. She wants to know, did you contract directly with suppliers for all hospital supplies? If so, do you have the data on how much you spent on these hospital supplies versus another hospital of comparable size? And she'd like to know how direct buying without the group purchasing organization compares.
That's a great question, Doctor. I need to get back to my hunting here, but I'm gonna try to answer that. I honestly, I'm not equipped to answer. That's a question for the hospital leadership. You're talking about like surgical supplies and things like that. Is that what she's referencing, Dr. Johnson? Or you know, beds to whatever type supplies a hospital would use?
Yeah, all the supplies that the hospital would use, and
yeah,
without negotiating with the group purchasing or organization.
Right. That, yeah, you'd have to ask the hospital leadership what they do on that. We're just helping them run their health plan.
Okay,
Sorry, I couldn't answer that question. That's out of our scope. I apologize.
okay. And do you see this working with within system hospitals or like these big corporate hospitals, or do you think this is more effective for small community hospitals and rural care centers?
I think it can work anywhere, Dr. Johnson. I mean, Mercy Hospital up there in Kansas City is doing some cool stuff. I was at a conference, ACO Direct Contract Symposium conference a few weeks ago, and heard from the person at Mercy. So I think it's possible in any, but when you look at, HCA, Tenet, CHS, I mean, that's probably a little tough. And those hospitals, we have a lot of experience direct contracting, and they're not the easiest to work with. That's what I'll say. But I think it's probably smaller systems, but I do believe it's possible. It's just it's up to that company. I mean, what we do, Dr. Johnson, is, I say it's not different. It's right. It's the right thing to do. And they don't want to hear that. And they're in bed with the bukas, think about how these hospitals contract and work. So a lot of them are not going to be open to this. But when your back's against the wall, you got to do things. And I think if you were to poll those employees in that hospital and ask them this, do you want single payer system, or do you want what we have with fair costs? I guarantee you they're going to say, we want fair costs. We don't want single payer. Why would they? Free care, free direct primary care. So it absolutely is possible. You just have to get to the right leadership to discuss it.
All right, great, Carl. There's a couple more questions coming in, but we're going to save those to the end, and let's let Dr. Page give her points about rural care. Thank you.
Thank you, Dr. Johnson. Make sure my screen comes up. So I'm going to focus on some of the issues related to the hospital closures in the rural areas and try to explain why it's different than the corporate hospital problems that you see in the urban areas of the United States. And I'm trying to get my slide to work. Brendan, if you can help me. I'm not getting a movement here. So Dr. Johnson had brought up the food, fiber, and fuel of our nation is coming from our rural areas. This is why it's so very important that we tend to the needs of our rural areas, and that includes making sure that the hospitals are healthy. And farming and ranching, which is primarily the occupation of the people that are living in these areas, is one of the most dangerous jobs in the United States. And so trauma is an important issue that needs to be addressed in these hospitals. And so it's very hard when you can't keep a surgeon in a hospital to be able to meet the needs of your community. And not only that, most people don't realize that in the rural areas, all of the highway accidents, car accidents, are going to end up in the rural hospitals first. Because they are transported to the nearest facility. Another reason why keeping these hospitals viable is so important. And Texas, unfortunately, leads the way in the nation for rural hospital closures. We've had over 21 closures now since 2013. I think Tennessee follows us, and then Georgia. And 72 of our counties do not have a hospital. We started off with 300 hospitals in the 1960s, and now we're down to 161. This is a diagram that illustrates the major reason for the hospital closures in the rural areas. In the 1960s, it was government regulation that started the first wave. Again in the 80s, and then in 2010. Every time the government imposed sweeping regulation on the hospitals, we had a wave of closures in the rural areas. The major contributing factors to rural hospital closures are EHRs as one of them, because the cost of changing software is huge when you have a small financial margin, that like what they have in the rural hospitals. They don't have the patient volume or the type of patient population to support that kind of cost. They also have the highest levels of uninsured in the nation and higher levels of Medicaid and Medicare, which makes them very dependent on the government reimbursement for their income. So when Medicaid underpays or Medicare cuts end up hurting the rural hospitals, it can close a hospital quickly. And that's what has been happening. So just for example, in Texas, the Medicaid underpayment amounts to about $65 million to the hospitals, and Medicare cuts about $50 million a year. Some of the regulatory costs that is imposed on the hospitals that tends to be a problem is the unfunded indigent care that's mandated. That's paid for by property tax, and if you've got a small community, you're not going to be able to sustain that. Another thing that a lot of people don't consider is the quality measures that are imposed on hospitals in general can really hurt rural hospitals because they're so costly. And one of the examples is sepsis workups. They're the most common admitting diagnosis for cancer patients, and yet most of them don't have sepsis when they are admitted into the hospital. It's an inappropriate application of the checkbox protocol, actually, that ends up forcing a sepsis workup that was unnecessary. If you do that too many times in a rural hospital, you're going to bankrupt them because it's a very costly and unnecessary diagnosis and treatment cascade. Another problem that the rural hospitals have is just simply the federal regulation imposed by their definitions of what qualifies them for reimbursement. So there are lots of rules. For example, a 96-hour rule that requires the hospital a critical access hospital to discharge or transfer a patient within 96 hours or they don't get paid. And that's really an unreasonable imposition to put on a rural hospital, because if the patient needs to be there longer, then it's extremely expensive to transfer them, and it would be inappropriate to discharge them. And again, the dependency on Medicare and Medicaid is what makes rural hospitals so vulnerable, because they don't have the patient volume and the patient population to sustain the burdens that come with that reimbursement. And some of the things that contribute to that are just the many federal rules. And that's where we need to make changes. We need to change some of the definitions that make it impossible for them to operate in a normal fashion, and look at how they're reimbursed, which the reimbursement tends to benefit the big corporate hospitals in urban areas, but they punish rural hospitals. The physician shortage that we're seeing across the nation is really in many ways a physician time shortage, and we have to keep that in mind too. Sometimes what we call a physician shortage isn't really the number of bodies, but the amount of time the physicians have to see patients. And just an example in Texas, now what's happened in the rural areas with physicians, we have 32 counties with no physician at all, and 157 counties with obstetrician. And obstetrics is a growth factor in a community. If you can't sustain an obstetrician, if you can't provide that kind of care for families, then you're going to have a really hard time growing a community and keeping it viable. And this map demonstrates how bad our situation is. The red dots are the hospitals that have no labor and delivery in Texas. The green ones are rural hospitals that have labor and delivery. And many hospitals can only provide labor and delivery on an emergency basis. So some of the solutions are actually, we're going to have to come up with alternatives to Medicare and Medicaid, because that dependency is part of what's creating the problem. And also investing in growth industry models. And one county in Kentucky actually did that with obstetrics, and they were able to turn around their hospital situations by making obstetrics more available and providing good care, which grew families, and it made it easier for families to feel comfortable staying in that area because they knew that they could get the care they needed. Another way that we can increase the number of physicians that are in the rural areas is by looking at how we train our young physicians and how we recruit them. And they found that physicians will stay in a rural area if they've grown up in a rural area. And one of the biggest problems with the residency programs is that the students that enter them intending to go to a rural area find out they don't really like it there if they've never had the experience, and they don't stay. And so what one school in Texas did was create a 7-year primary care pathway program. This was at UNT in Fort Worth. And they used federal grants to collaborate with rural areas that had a community college, a hospital with a residency program. And they were able to recruit students beginning in high school. They would take promising students who were interested in medicine and start them in a more intensive training program in the junior college there in the community. And after 2 years, they would be able to then go immediately to the university in Denton, finish the 3rd year there. And if they succeeded in their program, which was, it was a very demanding program, then they were able to be granted immediate admission into medical school. So some of the parts of the program that were really beneficial were the intensive, the enriching programs that they gave them during the summertime. They kept them in touch with clinics in the rural areas. So the area that they were recruited from provided clinical experience and guidance to them during the summer, so that they always had exposure to clinical experience. And this kept their interest in rural medicine and also kept them in touch with the community they were recruited from. After they finished medical school, the agreement is that they return to their community and do the residency in the place that they were recruited from. And this program's been working well, and it's allowing the students to be able to meet the needs of the rural community. Excuse me. So I think that the rural medicine is one of the areas, because we have such a high need and because the current system's not working for it, it's a good opportunity for us to develop a new model of hospital care and use some of the innovative ideas that Mr. Schuessler presented and other people have come up with, and let it be a foundation for changes in medicine for the future. And that's it. Thank you.
Hey, Nikki, you're muted if you're talking. Hey, Nikki, you muted.
Yes, I am muted. Thank you. I see one question here. My son would like information about how to apply for the student program. Dr. Page, do you have any information about that you were speaking of?
Oh, the program that I was talking about is it's at UNT at the Texas College of Osteopathic Medicine, and Dr. Lisa Nash runs the program.
All right, thank you for that. All right, continuing on, Mr. Andy Mangione, you're up.
Thank you, Sheila. Thank you, Dr. Page. Thank you, Dr. Johnson. Thank you, Carl. I'm Andy Mangione with AMAC, and AMAC is an acronym for the Association of Mature American Citizens. For those who are unfamiliar with us, we are a chief competitor, the chief competitor to AARP. We're a member benefits organization for Americans who are age 50 plus, 2.2 million members across the country. And I appreciate the opportunity to join this panel to talk about charity care. Specifically, nonprofit hospitals and their affiliate facilities all have an obligation to meet the needs of their patient population, including the needs of the uninsured patient. And many facilities are faced with the challenge of obtaining sufficient physician services or physician coverage for the reasons Dr. Page just went through, among others. Facilities have physician employment arrangements that stipulate that they must provide charity care, but most don't have the full complement of physicians across the spectrum of specialties to provide all the necessary professional needs. Several factors, including those greatly articulated by Dr. Page, but also including professional fees and liability considerations, limit the number of qualified physicians that are willing and able to provide charity care. In some states, it's extremely difficult or nearly impossible for physicians to find charity care for their patients. And except for free clinics, there's not a whole lot of advertising very publicly for facilities that offer free services. And some free clinics that do advertise report a 6-month waiting period to see new patients. So it's a challenge to find physicians to do charity care and to find the facilities that provide it. Also, charity care financially restricts physicians. Physicians receive no tax benefits for providing charity care. They cannot write off the cost of charity care from their personal or business taxes. The current tax code only allows for deductions for certain out-of-pocket expenses in providing charity care, like travel expenses, but it does not allow for such deductions for the value of a physician's time or for the professional service itself. So AMAC is aware of all this, and we wanted to come up with a way, how could we assist physicians in providing more charity care and expanding access to it? So we came up with legislation. This bill is called, it's House Resolution 856. It is the Physician Pro Bono Care Act of 2019. We are currently seeking co-sponsors for this in Washington. We have 20 or so bipartisan co-sponsors for this bill. And what it does, HR 856 allows physicians to provide pro bono care to Medicaid and CHIP eligible patients in their offices. So physicians would take a simple tax deduction, we estimate at 32% because that's the highest allowable under the tax law, in place of taking Medicaid reimbursement. So they will have the option to take a tax deduction or accept assignment from Medicaid and CHIP. The deduction would be based upon the value of the services they provide, based on either the Medicare reimbursement rate or their usual and customary posted fees in the state or county in which they're located. Now, right now, I just want to run some numbers by you to show the significance of the savings to Medicaid with HR 856. There are 50.8 million Medicaid and CHIP eligible patients. They visited a primary care physician in 2015. Medicaid paid on average $106 for these 45-minute visits. Under House Resolution 856 of the Physician Pro Bono Care Act, if these same patients sought care at that same average of $160 for an office visit, and the physician was allowed to take a 32% tax deduction, the cost of this visit to Medicaid would be $50. And the savings generated by, for the Medicaid and CHIP program by the Physician Pro Bono Care Act would be about $2.8 billion, or less than 50% of what Medicaid pays out. And everybody on this call, or everybody that are tuning in for this panel, knows that patients, low-income patients, also seek primary care, usually in emergency rooms. 20 million Medicaid and CHIP eligible patients sought care at least one time in an emergency room in 2015. Medicaid paid $1,000, over $1,000 per ER visit, that cost the program over $20 billion. If only 7 million of these nearly 20 million patients went one time to a primary care physician at an average of $160, and that physician was able to take that 32% tax deduction under the Physician Pro Bono Care Act, the cost to the government would be $358 million in tax deductions and not reimbursements. That's 1/20th the cost to the Medicaid, the payout that Medicaid was paying for the ER visit, and would save the program $6.6 billion. And that's for one visit only. So the bill will increase access to medical care for the poor by providing an incentive for physicians to see more of this population. It also guarantees an alternative to institutional care and the corresponding hospital emergency room costs that Medicaid and the CHIP programs pay out. It'll reduce the federal and state demand for reimbursements by allowing patients from these programs to visit primary care physicians for non-emergent situations. We're going to extend this bill to include dentists, podiatrists, and chiropractors. So what we think this bill would do would increase the quality of care, because that Medicaid patient will be able to establish a relationship with a primary care physician who now has the option, this is an option, to take a tax deduction instead of going through the cumbersome process to get the chintzy reimbursement from Medicaid. So we think that relationships will be established. We also think that health outcomes will rise because of those relationships. So what the bill does is give physicians the opportunity to do charity care in their own offices and be able to take a tax deduction for their time and their professional services. As I said before, we are currently seeking co-sponsors on Capitol Hill. We have about 20 right now on both sides of the aisle. And I just want to thank the panel for the opportunity to talk about charity care, to join this esteemed group, and to talk about AMAC and our House Resolution 856, the Physician Pro Bono Care Act. And that's what I have.
All right. Thank you, Mr. Mangione. There is a question for you. Brian Sachs, love this idea. Curious on any hidden legal pitfalls for physicians, and why only Medicaid and CHIP?
Well, we started with Medicaid and CHIP because they are the most vulnerable, okay? And AMAC is a member of the Free2Care Coalition. We've had a number of discussions with physicians, informal, that tell us, I would see more Medicaid patients if I didn't have to go through the process. They're not opposed to seeing these patients. It's the process of getting reimbursed, however chintzy that it is, okay, that turns physicians off, and they spend a lot of time chasing down these payers to get paid. So we thought we'd start with the most vulnerable, low-income individuals and families, as look, to reform healthcare is a colossal, multifaceted project. We thought we'd start with low-income people first. That's why we took a look at this and then expanded based on the reaction and if we're successful in getting this bill passed. As far as there's a Good Samaritan provision that's built in there that should shield people from legal liabilities. That's built into the bill.
That's great. Excellent. I think that's a excellent solution. So easy to implement. I don't even understand this bill.
You're right. And Dr. Johnson, if I could just say, this is just a simple change to the IRS tax code. And to kind of piggyback on what Dr. Page was talking about regarding rural healthcare, this could be a stopgap in an area where a rural hospital is closed. How many primary care offices does that Medicaid patient pass up to seek primary care in the emergency room? So we know that rural areas are getting they're getting hard hit with these closures. We think that this bill could be a stopgap in a primary care perspective in an area that lost a rural hospital.
Absolutely agree with that. And with all the stats we just heard about for rural communities, high reliance on Medicaid and Medicare.
Exactly.
This would definitely make a large impact, and it's just so simple to do. And I bet if we were to poll the physicians participating in this, or we could find out that most physicians would actually do more pro bono care if they could, and if they could actually get reimbursed. People don't realize that physicians still do need to keep their practices open, and you can't keep your practice open if you're giving away care and not getting anything for it at all. And also not facing penalties and bureaucratic, mountains of paperwork to have to be able to do it. So, I'm sure the incentive is there.
Exactly right, Dr. Johnson. Physicians, it's not like they're not used to providing charity care. They want to do charity care. We'd like to give them the opportunity to have them do it in their office. I don't think that's asking much. And the conversations we have with politicians on Capitol Hill, we get a lot of heads nodding. We really do. They feel for patients. Okay, getting them to commit is another story as far as co-sponsorship goes. But we're doing everything we can, and we're doing a full court press on Capitol Hill to get this bill more co-sponsors, get it to the Florida House. We're working the Senate as well. We just met with Senator Mike Braun of Indiana yesterday, who really likes this bill, and healthcare reform is high on his priority list. So we're getting a lot of traction for this, and we're happy to. We're just happy to do this work on behalf of the poor and on behalf of physicians who want to do this work.
What do you think that physicians who are out there practicing in the communities can do to actually help push this act forward?
I think they can join excuse me, Dr. Johnson. I think they could join the coalition. All right. I think they can pick up the phone and they can call their congressman and say, would you please support HR 856? Every legislative assistant and legislative director in Capitol Hill has access to all the bills that have been filed. This bill has been sponsored. It was sponsored, it's been introduced, so it's on the record, and they could have their congressman familiarize themselves, and they can with the bill, and the physicians out there can ask their congressman to acquaint themselves with HR 856 and become a co-sponsor. As I mentioned before, we've got members of Congress on both sides of the aisle that are sponsoring this.
Where does AARP stand on this bill?
We have reached out to AARP, and we don't get a whole lot of response from them, unfortunately. We'd like to work with them on specific issues. They've got a different agenda with regard to healthcare reform. We have a tendency to look through the problems that are facing America, and in specific healthcare reform, through the lens of free markets. And we find ourselves usually, as much as we'd like to work with another large senior organization, we find ourselves, and I would say AARP finds themselves on opposite ends on how to solve problems like healthcare, the solvency of Social Security, and et cetera. It's not like we don't want to work with them, Dr. Johnson. We just don't have much success in doing so.
Interesting. And what's been the biggest pushback, either from Washington or from outside influencers?
There really hasn't been pushback. If anything, it's the problem we're having is getting a politician to make a commitment to this thing, getting them to commit to anything. Everybody's head's not in agreement. Okay, one office said, well, they didn't think the 32 tax deduction was enough to incentivize physicians. And I said, hey, you guys could mark this up. You can make it a 50% deduction. You could do whatever you want. And that was a good objection. But nobody has said it won't work. Everybody recognizes the need for charity care. They just need to have the picture painted that doctors have to, must be empowered to do this in their offices. And they were unaware that doctors are not able to write off or take a deduction for their professional services. They're aware that they can take their travel expenses to drive to the free clinic, but they do get the idea that this will increase access. But nobody has said it was a bad bill. If anything, it's getting a politician to commit to co-sponsoring this. So we haven't heard anybody say this will never work. Most people say, in fact, everyone I've talked to said, boy, this is a great opportunity. Let me think about it. And getting them to move from thinking to co-sponsoring is where we're at right now.
Okay. There's another question for you. I believe this is directed to you from Ernest Sussman. Be interesting if other specialties establish urgent conditions that could be handled in their office also. What are your thoughts on this?
I think the bill can be expanded. We think this is just the beginning. Okay, we think this is just the beginning of a free market solution that will empower physicians across the board, above and beyond primary care.
Awesome. I agree with you. Healthcare, this medical care mess that we have right now in the United States it is huge. So we do have to tackle piece by piece. There's no way one sweeping piece of legislation is going to fix all the problems we have. We've seen this happen with the Affordable Care Act. So there's too many special interests that try to get a piece in there. So I think tackling it bit by bit, putting all the bits of the puzzle together is going to be the best way to tackle this. So this is a great start. Let me just I think that's it for the questions that are directed to you, Andy. Thank you very much. This was awesome. Well done. Let's just double check and make sure there are no other questions. Dr. Maz has a thought, more a thought than a question. Much of America views physicians as wildly wealthy, not the reality, especially for many debt-saddled young doctors. Pointing out the doctor debt burden and how this bill could help, especially these younger physicians, might be helpful too.
Absolutely.
Yeah. Okay. And I think there was also one more question for Carl. Are you still here, Carl?
He's muted.
Yes, ma'am. I'm here.
Okay. There's
Deer,
one more
there have
question.
been no deer. I had a feral cat run by me.
Darn.
I saw a feral cat, but I didn't do anything.
Okay. Actually, there's two questions for you. One's from Dr. Bob Campbell. The DC powers are out there trying to basically crush DPC. Will BUCAs come after you if you grow in scale? And is there any evidence that this is happening right now?
Well, I can tell you this much, and I'm gonna be careful. Mr. Blatt told me to, be careful, but I'm gonna tell it like it is. All right, I'm gonna tell you something. We're working with a school district, and the CEO of one of the BUCAs, $45 million CEO a year, not the president of the state, the head guy, came down to meet with them with the things we're doing. This is a cartel, folks. We have another city we're working with that the person we're partnering with was approached by one of the BUCAs asking, "Hey, what are you doing over here?" I'm trying to help the city. Well, we don't like that. I mean, it is a cartel. It's an organized crime mafia. You pick your term. Yeah, they will. Look, I have a Schuessler stick, Dr. Johnson. It's a metal rod with a mirror attached to it. So before I crank my car up, I use it every day. So yeah, it's going to cause problems, folks. But guys, you got to be tough and you got to do something. I watched my dad. I mean, he had a great career, but I watched the stuff he went through, and we just have to stand up and fight. But I know the DPC challenges. Dr. Gross, Dr. Dr. Gold. Dr. Umber and everybody's up there fighting, and I apologize I left anybody off, but you can beat them and you can win, and we just have to do it one employer at a time. And I'd love to scale it. I'm a member of the Health Rosetta, and I've got about 130 advisors that think like I do, and we're all trying to work together to scale this, Nicole. And but yeah, absolutely. But they're not going to go quietly, guys. One last thing, I apologize for rambling on. Who knows how much the healthcare industry spends in lobbying? Anybody? I know nobody can talk because they're muted. it's over
right.
$600 million. $600 million. Now I thought it'd be billions. 600 million. Do you know how much defense, aerospace, and oil and gas spent? They're kind of big industry, somewhat. How much do you think they spent, Dr. Johnson? $315 million. The healthcare industry spent twice as much as those three huge industries combined. So, and a lot of that's coming from the pharmacy, from all of that. So, and obviously the insurance company. So, I'd love to talk to you, doctor. Absolutely. Let's go. I'm suited up and ready to roll. I got my rifle. Let's go.
Okay. And I think there's one last question just to wrap up for you. Do you know how many mid-level practitioners were used in your model that you presented to us versus actual physicians?
Mid-level practice, a great question. We've got the two doctors, Dr. Crouch and Dr. Gross, the DPC practice. and just really any doctor that is employed at the hospital. I can't get more specific. I mean, they hired their first full-time surgeon, hope to bring obstetrics back. But we use doctors all over the country wherever the people require care. So, we did have a couple. I will tell one fast story. We had 3 deliveries at a very, very expensive cartelish hospital, as I like to call it. And by the way, the hospital leadership, when I came and met them, I said, the cartel, and they go, do what? And then as we were talking to a lot of hospitals, they, started to kind of see that. But we negotiated, this particular hospital charges $37,000 for a vaginal birth, Dr. Johnson. $37,000. I told my dad that, and he about fell out of his chair. We were able to negotiate a cash price for $7,500. That's what you can do. And the other thing with these hospitals, folks, one last thing. You want to help these hospitals, you want these rural hospitals, design health plans that pay the hospital 30 days in advance, like we did that delivery, or that pay on the spot, or pay within 30 days. Most of the FUCAs are 90-day, accounts receivable. So there are ways to do this, and these hospitals will talk. You do not have to be IBM to negotiate a contract with a hospital. You do not.
All right. Thanks to everybody for attending the discussion. I think we're off to a great start this morning with some actual solutions in this fight. One other request for Andy Mangione, could you provide a 1-page summary for Free2Care that we can share with members in our individual organizations, Bono Care Act?
I would be happy to.
Awesome. All right. Thanks, everybody. I'm going to turn it back over to Brennan. And
thank y'all. Have a great day. Go Dogs.
All right, everyone. Well, that was very informative, and thank you for your time this morning. And now we're going to take a short minute break, and I'm going to transfer all the panelists off now and bring all the other ones. Need to hop up and go do something. Now's the time to do it. So let's see here.
Carl, you make me want to be a Gators fan.
Oh no, why's that? Oh no, Dave, what did I do wrong today?
Just to be able to talk trash with you.
All right.
I don't have a good thanks. I don't have a good feeling about today. We've gotten worse every week, so hopefully we'll turn around. But thank y'all so much, and I appreciate the opportunity to be a part of this. This is awesome. I watched some of it yesterday. It's really good. I'm gonna watch Marni, and I'm gonna watch Dr. Dickerson and some of them. So,
Carl,
well.
you set a high bar. Next year, I'm going to have to be jumping out of an airplane or something to overcome a tree stand as a backdrop. That's pretty good.
Well, thank you. I don't think it's gonna be good for the hunting, but yeah.
Let's see here. All right,
Good morning to you.
Carl, I'm about to
mute
off the video here. Yeah, I'm about to bump you
Okay,
up.
that's fine.
All right.
And we're just waiting on Marni, I believe.
Yeah. We have a couple dial in. Oh, there we go. So we have a couple attendees that have dialed in. Marni, if that is you, let's see here. Raise your hand. All I can see is a number.
Brennan, this is Jeff Cantor, if you can see me in the system.
I do see you. Let's see here.
I don't have a camera, unfortunately.
Okay. Well, that works.
I do have a voice.
That'll work.
Good morning, Jeff.
Good morning, David.
Hey, let me try to get in touch with Marni. David, you want to go ahead and start?
Would love to. Good morning, everybody. And hopefully we'll have our other panelists join here in just a moment. I do want to say, as a follow-up to our previous panel, there was a request to have AMAC submit a one-pager on the bill that they're supporting, the physician pro bono bill. And Andy, if you could send that to me, I will post it on the website at free2care.org, and we'll have it on the newsroom so that people can disseminate the web link and be able to share that on social media as well. The website again is free2care.org. But I think that was a wonderful segue to talk about current legislation and what's going on in DC and various states. I think this conversation will focus more on what's happening at the federal level. There's a lot going on. We don't expect much to happen because of it being a divided Congress. Most of the healthcare work that has been happening has been due to the president in his actions through executive order, but there are a number of things that are presenting through the House, and again, the pro bono bill is one of them. And those are always good ones when you can get bipartisan support. Sometimes it's also bad, and we'll talk about that here shortly. Some of the things that we want to talk about, of course, the ones that we have, as a coalition, have come out and supported and opposed. HR 3594, which is the Healthcare Freedom Account bill. The coalition is in support of that. It expands, essentially, it really changes HSAs and makes them more usable. It doubles the contributions, and it decouples it from high deductible health plans. It really gives the consumer, or the individual, the ability to do more with their own money, which is always a good thing. We are vehemently opposed to HR 3708. I think Chad will talk about that. That's the Primary Care Enhancement Act of 2019. It's definitely a misnomer. It doesn't enhance it at all. And some of the big drug bills, we've got a drug pricing panel later on. I don't know if they'll talk about this, but they may. But HR 3, which is Nancy Pelosi's bill on drug pricing, that is a very concerning bill because it is an effort to cap not only federal programs, but the private market as well. It is a step towards single payer without saying it, which that is the biggest concern for me. And then the Prescription Drug Pricing Reduction Act of 2019, which is the Grassley-Wyden bill, and that has some problematic issues. And then, of course, the various executive orders, which there have been quite a few of those, but we're thankful to the administration for their effort and their interest in making healthcare more free and more patient-centric, which is a big motivation for us. With that being said, I'm going to allow each of our panelists to introduce themselves. We'll start with Dr. Savage and then go on to Marni and then Mr. Cantor. So please tell us who you are and why you do what you do.
Well, thanks, David. My name is Dr. Chad Savage, and for those of you who don't know me, I'm a direct primary care doctor, and I'm the president of DPC Action. And actually, some of my colleagues were mentioned just in the last panel, and Kat Lindley, who's one of our board members, actually presented yesterday, Dr. Lee Gross, Dr. Josh Umber, Dr. Kim Korba, and we're basically a healthcare advocacy group, and we try to encourage legislation that's going to be supportive of free markets and direct primary care. And I'm into this for very obvious reasons as a direct primary care doctor. I've been doing this for about 4.5 years. Some of my colleagues even longer, and we've been swimming upstream against a system that is not conducive to free market and direct primary care in our system. So we're trying to look out and stay vigilant for bad actors who are trying to squeeze us out of the market. Did you want me, David, to go into specifically our concerns, or did you want me to hand that off to someone else then?
No, I'd absolutely like to have you talk about what it is that you're doing, the issues that you see, and then most importantly, give those that are watching this video the ability to act. Give them some homework that they can work on, calls to make, emails to make, and who to make them to. So we want to make this as educational and resource-based as possible.
Absolutely. So let me give a little bit of background. So the big battle that's going on right now, and those who are engaged in social media may have seen a lot of hubbub about this over the last week or two, is there's a bill right now that just came out of the Ways and Means Committee called 3708. And this is regarding HSAs. And on the surface, it purports to actually help us as direct primary care doctors. And there's been quite a bit of contention and schism that has developed in the DPC community, sadly, regarding this. Many well-intended people on both sides. But the long story short is HSAs, which all of you know are a fantastic savings modality, pre-tax contribution, pre-tax growth, and pre-tax use. It's better than an IRA, can be used for almost any service in medical care. But there's been debate as to whether or not you can actually use it for direct primary care. And one of the reasons for that is that HSAs came into existence in the 2000s before direct primary care was even in existence. People have been using them without any recourse so far over the last 10 years. But in 2014, I believe it was, then IRS Commissioner Koskinen sent a letter to a senator saying that he did not believe that they could be used for DPC services. Now, understand that that was not legislation, that was not regulation, and many people's complaint about regulation is it circumvents the legislative process and gives it, a fourth wing of government quite a bit of power. Well, this is beyond that. He even circumvented regulation and basically in a letter to another person, which is totally informal, created something that is being treated as though it is in fact law. So to try to clarify that, several years ago, there was an HR 365 that was introduced, and it was very short, very sweet, very simple. Basically said, yes, DPC is a qualified medical expense. It would have cleared it up. Unfortunately, it didn't pass that year. Last year, there was another bill that replaced it, and suddenly it came back, but not as the original 365. It came back with many, many qualifiers and stipulations, and there are people who try to explain those away, but nonetheless, was a very different beast than the original very good bill that came out, 365. That one never got out of committee. And now we see this year's version, which is largely unchanged from last year's HR 3708. And the concern is this bill looks like it actually may have some wheels and may actually clear through the House. So many people say, okay, well, the intent of this bill is to make HSAs, a DPC rather a qualified HSA expense. But there are so many stipulations in this bill that we actually feel that it is harmful, and that there's probably not a big rush to get anything through, because in June of this last year, President Trump signed an executive order instructing the Treasury Department to create regulation that allows for DPC to become an HSA qualified expense. And that should be coming out within the next 4 to 6 weeks, as they had a 180-day time period to do so. So understand the original push to really get this as an HSA qualified expense, that time period, that may no longer be, given this executive order, such an urgent thing. And many compromises were being made in this bill with the belief that this had to be rushed through. We are also hearing word that a very good bill may be about to be released. So again, the indication to rush through a bad bill is just not there. So some of our concerns, and there are quite a few, if you look through the bill, and I don't want to get too nuanced and boring to people, but right off the bat, it says that an HSA can only be used for a fixed periodic payment. And for what that means for those who aren't familiar with DPC, so we're primarily a membership model. You pay every month. And many people talk about getting unlimited medical office visits. But in fact, if you look at the contracts of many DPC doctors, that's actually not true. Some are worded that way, but their legal experts have warned many DPC docs that we have to be careful about structuring them that way, because if you say you're going to provide unlimited medical visits, that actually it may be an impossibility to actually come through in that promise. So many will say something like, well, you're allowed up to 20, 25 visits a year under this contract, something that realistically they're not going to exhaust. But if they do, any fees above which, you would have a per visit fee. This bill specifically states that if you do that, you would not be able to use HSAs for those kind of offices, which is a decent share of the DPC practices out there right now. And people would have to go back, restructure their contracts, and perhaps make them in a way that's very unfavorable. It also offers the first cap on HSA use that's ever existed. It sets a ceiling for what you can charge as a direct primary care practice. As I understand it, does not allow balance billing above that, even if somebody wished. And the analogy on that, so some people will hear that and go, oh, that's direct primary care doctors being greedy because they want to charge a higher rate. Understand there's something called the market. and the fact that people control these funds themselves, that is a much better regulator of the threshold of what these fees will go for than is ever any arbitrary governmental cutoff. So the analogy is if you had a surgery and you wanted to pay for it with your HSA, and the government were now to step in and say, okay, you can pay for that surgery up to $1,000. Anything above that you can't do, so therefore you can't use your HSA. So there's some real problems with that, and it's a bad precedent not only for DPC, but actually other medical services. The other thing is it also excludes specialists from engaging in these kind of arrangements. And that's actually really, really concerning. And people say, well, why are you worried? Because you're a direct primary care doc, that won't affect you. And that's true directly, it won't. But that doesn't mean that we should support something that's going to hurt other people just because it doesn't hurt us. The wording is specific and specifically states certain specialties and not others. The worry about this is now if a specialist should decide to do this type of arrangement, they would, to actually overcome this legislation, would have to go through likely a several-year process, hopefully with a lot of support, to get new legislation, including them under a kind of direct specialty care kind of arrangement. And it's not just that they actually specifically state this can only be done with certain specialties, which the omission of the others is actually very, very important and could really hurt any of our subspecialty colleagues who are trying to do these kind of models, perhaps some even on this call right now. So they really need to be aware that this bill could actually hurt their efforts. There's also a pharmacy exclusion indicating that if doctors were to dispense pharmaceuticals under that monthly membership, that would make them a non-qualified expense, which seems just kind of ridiculous. If you're trying to consumerize and incentivize novel, innovative practice models, you wouldn't start putting barriers to innovation. And it also, and people will say, okay, well, again, I have a pharmacy, I dispense to my patients, very inexpensive. We get for 21 cents, we can dispense a month of Norvasc to our patients. That's how inexpensive these kind of drugs are. So it really is tackling some of the problems that are structurally in the healthcare system right now. We in direct primary care are addressing a lot of the pharmaceutical cost issues. But we do charge the 21 cents above that. So people who are in support of this bill argue, well, that wouldn't affect that. However, if I do an injection, and almost all direct primary care doctors do this, where if I do a joint injection, it's 30 cents a steroid. It's a needle. The actual cost of doing an injection is actually quite small. And the hassle of billing it, tracking it, et cetera, is actually above any benefit we would ever hope to derive from undergoing that process. So it's best to not have that sort of restriction, because if you now do a joint injection and don't charge separately for the 30 cents of dexamethasone you injected or whatever steroid you choose, you are now again excluded from HSA participation. To continue to go down, there's a real worry, and this is really pertinent for HSAs. There's, not to get too nitty gritty, but there's a 213 in the IRS code and a 223. 223 is for health plans. 213s are for qualified medical expenses. This bill supposedly corrects the HSA issue under the 223 section of the IRS code. The reason this is a concern is that even though the people who are framing this are claiming that the intent is that this will resolve the HSA issue and allow HSAs to be used for DPC, once it goes to the regulatory agencies and once they start using this flawed wording to create actual regulation around this bill, God knows what they will come up with. And they could say, well, you're a secondary health plan because you're under a 223 of the IRS code. And what that means, to have an HSA and contribute to it, you have to have a primary insurance, a high deductible health plan. If you have a secondary insurance, a plan, you cannot contribute to an HSA. So if they categorize us as a plan, you can contribute to an HSA, but you will, you can use your HSA, but you can't contribute to it, which would totally defeat the purpose of having an HSA. Now, and there are other issues with this bill too. So the big schism is there have been really good people who've been out there trying to get this bill passed, and they've been working for years. And I think at each stage of the process, they've made little compromises, and they're trying to get good scores for CBO and things of that sort. And again, I don't mean to slander them, but AAFP, the American Academy of Family Physicians, I'm an internist, I'm not part of them, has come out in support of this bill. And one of the concerns is in their actual letter of support, they indicate what a great support they are for direct primary care. And they're also supporting HR 2774. Now, why is that related? Because the reason why is that bill actually goes in the opposite direction. It says, again, things, if you pull people on the street, this is going to pull really well. They said under high deductible health plan, we're going to force your insurance company to cover 2 primary care visits per year with no copays and outside of your deductible. So that sounds great. However, if you think about what that actually does, that's forcing payments through the insurance company. You're washing those dollars through an insurance company. We're taking part of it. And in those situations, you make it very hard, again, to be a direct primary care doctor, to innovate. You're forcing it through the insurance mechanism, and you're going to kind of ensnare in servitude more doctors to insurance companies as things like direct primary care become more of a niche if you're forcing insurance-based payments. And people think, well, that's really taking it to the insurance companies. If you do that, that is not taking it to the insurance companies. They will increase the premium in excess of the cost of those visits to cover it, and then they'll be able to take a portion of that. So actually, it'll keep more money with the insurers.
Well, Dr. I wanted to jump in there real quickly, and I think everybody can see why I have members of your organization jump on calls when I talk to members and senators. I can say with great confidence that what you're hearing from Dr. Savage is more than what many of the lawmakers know. When we have spoken to them, what they have been told, and in fact, if you go to the Ways and Means Committee, where they took the voice vote to support this bill and pass it out of their committee onto to the general floor, which hasn't gotten there yet, they only discussed the caps. They only talked about having a set fee or a cap for that fee per individual and per family. There was no discussion about these very dangerous and detrimental exclusions that followed through. So when we reached out to members and senators, they didn't even know about the exclusions. And these are folks that may have co-sponsored in the House anyway. Some co-sponsors didn't even know about the exclusions. So don't assume that they've read the bill that the co-sponsor, sad to say, but that's the case. And we've seen that firsthand with this particular bill.
Yeah, and not only just read the bill, but read it and understand the wide-ranging implications of it. You've got to think 2 or 3 steps down. What does this, compromise mean? And a lot of times, mainly when you throw it to the regulatory agencies, it's not going to be very, very attractive once it goes through that whole process. And you're going to, fence in this burgeoning, innovative model and new things that are going to emerge that patients may like even better than the current DPC practices, which are very popular with their patients, will never be able to be created because it'll bump up against some regulation that never understood the implications of its existence. So I don't want to hog up too much time. There are other, a couple other bills too that I wanted to mention if we have the time, but let's
leave those for after we've had the other presentations. Absolutely. And bring those up for sure. I appreciate that. Thank you, Dr. Savage. Marni? Oh, we can't hear you. You must be on mute. Well, and we'll try to have more
on the left bottom of the screen. If you
we'll try to have more of these bills available on the website.
How's that?
Oh, there you are.
Am I live? Sorry.
You're live. Welcome.
Well, hello from sunny Florida, where it's about to be 87 degrees. Sorry, Carl, in the 30-degree deer stand. Thank you for having me. Do you want me to just kick off a little bit with a little bit about AID and where we are on the executive orders?
Absolutely.
Okay, so for those of you who don't know, I'm the executive director of the Association of Independent Doctors. We're a national nonprofit trade association that, as it sounds, represents the interests of independent doctors and works really hard to preserve them and explain to the media, consumers, lawmakers about why stopping the consolidation in healthcare, and in particular, letting doctors practice independent medicine without becoming corporate America, is really important for doctors and for patients. One thing that distinguishes us from a lot of the physician groups on this call is that we're not physician-led, and we think that's actually a strength. We were founded by 2 certified accountants in Winter Park, Florida, and a healthcare attorney. And they got together in 2013 and said, wow, this consolidation is really bad for America. And we're looking at this strictly from a business and financial aspect. And plus the accountants represent about 115 independent medical groups. And they were seeing firsthand the devastating effects that we're having when our own local association or health systems, we have Advent Health, which was formerly Florida Hospital, and Orlando Health, are both within a mile of each other, and we're the 26th largest metro, so we're Midland, but we have these giants in our community buying up medical groups, and they were seeing how taxes were coming out the tax rolls, and that was devastating the community, and how the office workers were losing their jobs, and the doctors were having to go to work and have to meet quotas and were burning out. So for all those reasons, they got together and said, hey, we really need to do something to help the independent doctors. They started the trade association in 2013. At the time, I was a health reporter. I was a senior health reporter at the Orlando Sentinel. I came out of the Los Angeles Times, which is a sister paper to the Sentinel. And I covered the story that they were starting this trade association, and one thing led to another. I became the executive director in 2014. So here we are. Some of you know that story. Some of you members are on the call, and I appreciate you. But we have a mission, and we've been driving in the same lane since we started. I'm really proud of the founders for having this vision. But I think everyone on this call, for the most part, will agree with here's what we do, and what we don't do is, there's a lot to be done. But we work on stopping the consolidation between hospitals and medical groups, because we think that drives up costs and burns out doctors and is bad for patients. We work for price transparency, which we'll talk about with regard to the executive order. We work to enforce antitrust laws, and our hope to stop the consolidation. And we have some connections with the FTC, and we've worked on them to shut down several mergers since we began. We would like to see the end of site neutrality, or we would like to see site neutrality and the end of inflated prices, reimbursements to hospitals, and reduced reimbursements to independent doctors, because we think that drives the consolidation. And finally, this is a big one, and we won't get into it on this call, maybe next year, David, but we would like to end the abuse of the tax exempt status by nonprofit hospitals. So 62% of the hospitals in our country are tax exempt and don't pay any property taxes at all and behave like for-profits. Their executives are getting multi-million-dollar salaries, and they're not really giving back the charitable care that they probably should be giving back once, the nuns are gone, but once upon a time, the nuns actually did charitable care in exchange for not paying taxes. And we think that is not happening as much as it should today. So with all that, that's who we are. And I've had the privilege, since I took over in this position, at having a seat at the table and trying to help doctors have a collective voice on the national stage. Doctors are really busy removing gallbladders and reading x-rays and delivering babies and fixing cataracts. And I can't do any of that, but I can communicate on their behalf. And so I've had the privilege of being on Capitol Hill many times and working with lawmakers and writing editorials and articles for the media, trying to communicate and patients understand what is going on and what they need to be concerned about. So that's sort of how we fin. We are nonpartisan. We don't side with anybody, but I have seen over my course of working in this position that we really need to work with who's ever in charge. And our administration just so happens to be in favor of what we all want. They had a big paper, a 114-page paper on reforming America's healthcare system through choice and competition. And when I read through that, and this was with Alex Azar and then our Secretary of Treasury Acosta and the Labor Secretary, they all came up with what we need to do to fix this. And it was right over the heart of the plate as far as we're concerned. It's about free market, it's about choice, it's about control, it's about transparency, it's about site neutrality. I was nodding my head vigorously. I've never been so excited about a government document in my life. So I thought, this administration really gets it. So what's standing between us and having those things happen? Well, it's Congress and special interests, as you probably know. So I worked with some people on getting the first executive order that we're going to talk about today, the transparency executive order, which President Trump signed on June 24th, and Dr. Savage referenced it in his call. That is, it's a really, really important first step in getting price transparency. And the hospitals, of course, don't want it. The insurance companies don't want it. And all those who are profiting from the opacity in our system don't want it. But we're trying really hard to work to get it. And what I think probably all of you on this call probably know this, but it's a huge obstacle. The special interests are paying an enormous amount of money. They're in the top 5 or 6 contributors to Congress every single year over year. They have $25–30 million that we know about, according to Open Secrets, and they're working really hard to shut these bills down, and they're being pretty successful. So the executive order that was signed, now goes into to get codified. From what I understand, and I've been trying, what we all need to do is work to observe the language changes when it starts saying real price transparency gets muddy to price estimates or prices. Want that, or what just patient owes. So the other side, opinion, the folks that we're up against would say, well, listen, I can have a baby in Boston for $5,000 hospital. How does an average help me? What I want to know is, where do I go to have the $5,000 birth vaginal delivery that also has the best outcome? So we want, obviously, outcome transparency as well as price transparency. Well, the other side doesn't really want that. They really want to keep all those cost estimates. And then they say, well, let's just talk about what the patient's out of pocket is. That's all, again, to protect how much they're making. No, we want complete price transparency. We want to know cash prices. And what I understand, according to an article yesterday that came out in the Wall Street Journal, is where we are on that, because it was supposed to be written into law by now, because the executive order was signed on June 24th, is that they are trying to hold the insurers accountable. It was one thing to ask the hospitals to produce all their prices, but they also want the insurers to produce theirs. And there's a lot of blowback about, well, that's, in violation of our right to free private trade and private contracts and all that. Well, the government would say, the administration would say, no, we think those prices need to be transparent. And then the other big argument is, well, it's just too much information. It's just too hard. And Americans don't care that much. When we do have price transparency, they don't even use it. Well, that's because the law that got passed in January that required hospitals to post their prices online are impossible to read. They're impenetrable. They're buried on page 42 of their websites. And they're of no use or value, really, because you can't even read the code. It's just difficult. So they have to be clear, accessible, and readily available. And then we think that patients will actually use them to shop and compare value and price. Of course, we know that will help independent doctors. That's what we're about. We're trying to see that patients can see, oh gosh, if I go to Dr. Jones, who's employed by the health system, or Dr. Brown, who's independent, I'm going to have a lot better care and have a lot more time with this doctor and a better outcome than if I go into this hospital system that's going to add facility fees and make sure that I stay within the health system and not necessarily go to the best provider. So that's important. We were discouraged by the fact that CMS tried to push site neutrality out this year. They tried to they pushed as far as they thought the law would allow them. So I guess I apologize if you all know some of this stuff, but CMS is not against site neutrality. They have been for it. Medicare would like to see site neutrality, and the Medicare Advisory Commission has been advising for site neutrality, the fact that a procedure should be reimbursed at the same price regardless of where it's performed, whether it's an independent doctor's office or a hospital outpatient setting. They've been for this all along.
I think we lost you, Marni.
But advises Congress. Can you hear me?
Yeah, I think it's getting to be pretty bad as far as the in and out. I think we missed quite a bit of what you just said. But as far if I can try to recap the site neutrality, CMS is in favor of it, but there was the rule from CMS only applied to E&M codes, only the physician encounter codes. But there was still a lawsuit that came from the hospital industry because they understood that that was going to be the first step and there would just be a slippery slope. And unfortunately, they won in court. which I hope that will come back again, and that's something that can be put into place or codified by Congress, because that is a big issue for patients and for physicians, and I hope that site neutrality gets more and more important. With regards to transparency, it's a big issue. Texas Public Policy Foundation, for which I'm a director, we co-sponsored some research with the Galen Institute, and I can put that on the Free2Care website as well for you all to read. But that's we absolutely are supportive of Marni, her organization, and patient rights advocate as well, to continue to push transparency, because if we don't know what we're buying or how much it is, how can we move forward and try to be good stewards? It's virtually impossible. So if there's was there anything else, Marni? Let's see if the connectivity got a little bit better.
I'm sorry. I'm at a Winter Park Women's Club function. I'm squirreled away in the back office, so I apologize if the reception is shaky.
It's better now.
No, but what you just said, I mean, we really want that price transparency. We think if patients can know the price, they will actually use it. It may take a learning curve, and that's why some of the FOs are saying you can't, the patients don't have the information. Once we give it to them, they don't even use it. It's because they don't know how to use it. But look at how we shop for houses through Zillow. Look at how we shop for cars. We get Kelley Blue Book online. Look how we shop for any appliance. We go online, we get the data, and the health industry saying, oh, there's just too much information. Look, we have Alexa, we have Uber, we have Google. They are crunching huge data sets of data every minute. It's in our hands, it's in our fingertips. Healthcare can't do this. It's not too hard. They just don't want to. So I don't think we are going to be able to work with this Congress based on how much money they're getting paid. They're not getting it from the independent doctors, but they're getting it from pharma, they're getting it from the hospital insurance companies, they're getting it from the AHA, the AMA, all of them, all the people who want to, I call them the opacifiers, the people who want to maintain the status quo and maintain the gravy train. But we need to take that house of cards down with utter, complete, clear transparency with pricing. So, and then one other thing, David, if I have a few minutes, is the other executive order that was signed on October 3rd about the Medicare. And that was really a shot over the bow against Medicare for All. And I got a seat, thanks to our friends at Patient Rights Advocates, in the second row of that. It was at the Villages in Florida, and was able to watch President Trump deliver the speech, which was really impressive. And Seema Verma was sitting on stage, Alex Azar, a bunch of other folks. And he said a few really important things that day. And forgetting all the politicking, which was happening, sure, but if you get right down to it, what he was saying is that Medicare is for seniors, and that's where it's going to stay, and we're not going to dilute it by getting it all mired around the whole country. But there was a section in the bill that has gotten some doctors worried, section number 5, and that was about leveling the provider, nurse practitioner, physician assistant, make them all equal in the eyes of the reimburser. And we don't like that at all. And so we believe at AID that doctors are doctors, and nurse practitioners and provider and nurse PAs are not. They shouldn't be paid the same amount. And the nurse practitioner and physician assistant should always be supervised by a doctor. So that's where we stand on that. However, we don't want to throw the baby out with the bathwater. There's a lot in this Medicare bill that's protective of seniors, that's protective of our free market. Frankly, they want choice, they want control, they want transparency. So I want to make sure we hang on to all that, and let's work within the system and within that executive order to not have that aspect of it, and continue to educate. We're all writing comments, which, by the way, I'm assured they'll read every one of them. Write the comments, get on the government website. And I've also learned, this is for folks who don't believe, but I'm also learned that they're not allowed to take any information outside of what's commented on. So I met with one of the top officers at CMS recently, and he said, Marni, if you write an article in medical economics that's really persuasive and convincing, we can't take that into consideration. It must come on the government website. So it's important to comment, folks, and use your invitation, use your links. Keep it short, tell them what you think, and they are listening. And I think that's encouraging, because our hope lies in the administration right now. It does not lie in Congress, my opinion. I hope that can.
And I'll say this. Thank you very much, Marni. If you don't think one or two people can make a difference, regarding the section 5 of the executive order. Karen Gallagher, and who's a part of Physicians for Patients, Nikki Johnson, Dr. Johnson, who was just in the previous panel as the president of that group. They put out a petition, and it got nearly within a month, I think, got 25,000 signatures. Within a week, it had over 20,000, and it got the attention of the White House, and they were able to get on a call with senior advisors. You can make a difference, and that kind of action, that kind of work will get you noticed. And that's what we do here as the coalition as well. We uplift each other and support each other and get each other access, because everybody has their gifts and their resources, and we share that with each other. Thank you, Marty. Jeff, are you still on the phone?
I am. I just have myself muted there.
All right. Well, tell us a little bit about yourself, Medibid, not Medibid, your organization, and how we can, what are you looking at, and what are you trying to achieve?
Sure. Thanks for having me today. This has been a fantastic event you put together here, I have to say, with some really super people I see both attending as well as participating. So that is pretty exciting. But it's also indicative of what I've been kind of preaching as part of the mantra of what we've been on to, is that the only way we're going to solve this whole dilemma is if we collectively fix it. We cannot look to government or legislators or third parties or other entities to make it happen. It's the individuals that are making up the actual reality of it, which are the consumers and the doctors. So this meeting is indicative of that. That's actually happening, because here we are banding together, whether we realize it or not. And then I've always said that the only way we're going to bring down this whole cartel, as it were, is by the death of 1,000 paper cuts. There's no sweeping legislation, as others have said, or anything that's going to make this happen. And frankly, you know, the sad part is the senior market is controlled by the government already with Medicare. And then, of course, they're trying to push it onto the balance of it. But we can't let the private side, the under 65 market, fall into any kind of government involvement whatsoever. If we kind of take a look at the, you know, the model of where we're trying to go, if we look at Atlas Shrugged as a prime example, you know, we need to change the people to change the legislative culture. And so that's what we're doing at yourfreedomhub.com, which is kind of the entity we've morphed into over time, is we're building that army of consumers, but that are free market oriented, that want cash price transparency, because they understand that, which is the way they are brought up in the current system. No one understands that there are prices. It's all about co-pays and, you know, what's my end of it. So they don't even understand it like they understand how cell phones work or gasoline prices work. And at the same time that we need to really get the outcomes out there as well, which we were just talking about a few minutes ago, for sure. So those are all really critical things. So we've kind of become kind of an intersection of a variety of things, because we start up being just a straight healthcare disruptor to try to drive the BUCAs and all those kind of organizations, not out of business, but to create a good consumer-oriented side where we turn the person into a cash-paying and cash-shopping consumer, so that now that they have a tool, they can go to the Surgical Center of Oklahoma, or they can get medications from overseas, or a whole variety of things that they could suddenly do when they figure out that they're in the driver's seat. And not surprisingly, outcomes are better, quality's better, the consumer likes it better, they're getting better services, and in the end, it's all less money. And 100% of it bypasses government and conventional insurance. So it's training the consumer to want to look for the DPC, to want to kind of patronize these types of places. And then, you know, it's funny that you mentioned Galen. We also had started doing, you know, it's already been for a while, podcasts concerning free market practitioners and as well as innovators. So every week we have great people on that talk about what they're doing in their little wheelhouse. You know, like we had Dr. Paula Muto with UberDoc on just the other week and stuff like that. So it's all these little different things that I was just saying, all these individual organizations and all these innovative doctors and consumers and people that are concocting new apps and whatever. None of that can work if it's something that's quote unquote covered. Then that's the end of it. That's the kiss of death the minute that word is in the same sentence. And so that's really what we've been being, this broader disruptor now across the entire health spectrum, because frankly, everybody, you know, says, oh, I've bought my insurance and now my health is all handled. Really? Are you going to eat today? I guess your health is not being handled by that BUCA or whatever you think you've put in place. It's really just protecting your wallet from this jiggered health cartel that exists out there when you really just, and then you're, like you said, they'll just raise prices or whatever. So you're just this unknowing shield, this useful idiot in the entire process. And that's really what we're all about, is becoming that water cooler where all the consumers can get together and find out about all this disruptive and interesting things that are beneficial to them, as well as for doctors and other organizations. So we're working, right, as an example, with the Republican Liberty Caucus and Liberty International and the Roads to Freedom Foundation and a whole array of national health federations. So all these different organizations that are pushing to kind of get to that consumer. But just like you were saying a minute ago, David, everybody's in their own little space. But how do we pull them all together, as it were? And so what you're doing is very good, because it's in like kind of that area where the doctors are kind of congregating, and some of these thought leader types and some of this legislative stuff that's happening. And we're kind of in a space where we're bringing even that larger sphere in there as well to network with you. Not that you're doing your thing over here and they're doing their thing over here, that we need to be all together. And so that's really like the rallying call, and the mission is for us to save ourselves.
Hey, Jeff?
Yes.
Oh, just wanted to make sure. Okay, very good. Well, I appreciate that. Are there any particular bills that you're following? And this is a question to the general group. Can you tell the audience, how do you follow certain bills? How do you know when certain things are there, that they're moving through the process? There are so many bills, especially at the federal level, but for those that are interested in what's happening in their state, how do you wrap your arms around something as significant as this? And I'm happy to share what we do, but with you all as with people with day jobs that don't do this for a living like I do, how do you do it?
I follow David Blatt. sorry, Ballot. No, it's very hard. Unfortunately, you could make a full-time job easily watching this. So, watch the sites. I'm going to plug our own, but like DPC Action, like Gallon, like the others that are advocating for you, because they're spending an immense amount of time in their own time and resources tracking these things. And even in those, I mean, it's interesting in the policy circles how occasionally something will come through and people who are incredibly connected and involved in this will be surprised. I didn't know that was there. So it's an immense challenge. But look to the organizations you trust that are really looking out for your best interests, and perhaps sign up for their newsletters and things of that sort.
I was going to say, this is Jeff Cantor commenting. That's a little bit of what we've been also building up in the background. We have a few initiatives that we're bringing out as a bit of an aggregator for some of that information, because you're exactly correct. If we know about this stuff, it's great, but we're very, minimal in having any impact. We need those consumers aligned. And so that's partially the idea of bringing this out to them as well, that they're cognizant of when, the AAPS makes a notice that this bill is taking place, so you should be calling your senators and so on. And so that's the other part of it. It's got to get out there, disseminated to the end user. And that's part of the way to track this stuff, is that we're keeping tabs on the broad array of this stuff just because we have to. And then also we do a lot of stuff in Washington. As an example, we're going to be November 15th. There's a big opioid conference at the American College and Surgeons Center being held by the College of Healthcare Trustees that we're a participant in. And so we're, networking and stuff in DC and building some other conduits to be able to disseminate information. So the end users getting up off the couch and making that phone call. And that's what's going to be critical to make any of these bills that we try to track here actually take place.
And Jeff, and we really appreciate all of you guys, with Chad and the group at DPC Action. You're empowering patients. Marni and your organization, you're empowering physicians to be independent. And Jeff, also empowering patients with My Freedom Hub to be able to take charge of their healthcare needs, use their own money, and experience that freedom. Your organization is aptly named. Any other points that you might want to bring up? Or Marni, how do you keep up? I wanted you to address that question as well. Oh, you're on mute.
One more time. David, what was that? I was typing about a question to Bob Campbell.
How do you keep up with what's going on at the federal level? How do you keep up with what bills that are out there that may be of importance to you, your organization, and the physicians you represent?
It's my network. It's you all and my doctors. My doctors bring me issues that are causing problems, like when they find out that Medicare is going to stop paying for a certain kind of PET scan in the cardiac lab and just shut them down. They're like, wait a minute, we need help there. So I read and I get a lot of stuff from my members and from my colleagues, such as you. I keep up with it and then try to keep my ear to the ground, and occasionally a lawmaker will bring something to my attention as well. So yeah, I just try, and then I get up there.
Another question for the three of you: What particular sites do you visit? Congress.gov. Is there any other website? And feel free to share your own if you're staying up to date with those types of bills that would be of importance to physicians or people that are interested in healthcare in general. While you're thinking, I will say Congress.gov. If you go in there, you can set alerts. So if there's a particular word that you want to look for, you can put in your email and it'll send you any alert that will trigger whenever that word is in a bill.
And when you find that bill, David, also you look at it and you find one you're interested in, they have updates. So they'll send alerts once that it passes out of committee or something of that sort too. So that's all on that website as well.
Very good. All right, well, we have some questions from the audience. Jeff, could you give the website for your organization, please? I've got somebody who's asking for that.
Sure, I'll give you that, and then a couple that I like to track as well. Ours is yourfreedomhub.com. And that's kind of still just a little bit under construction. So you'll see there's some links in there, but much will be added to that in short order. But that's a good beginning point. As far as sites to track for keeping tabs on stuff that's going on is the NHF.com, which that's the National Health Federation. They're the ones that sits at the Codex Alimentarius at The Hague and controls global food supplies. That's an important one. They have a lot of notices on what's going on that international level. And then AAPSonline.org, which is the Association of American Physicians and Surgeons, has a very good legislative feed on their site, and you can subscribe to that. And then the FMMA, the Free Market Medical Association, oftentimes has some good information. I mean, there's a wealth of them for sure. Like I said, we're tracking a lot, but those are some real high profile ones worth monitoring.
Very good. I appreciate that. Marni, I'd like for you to address, there was a question, it alluded to this, but I wanted to flesh it out a little bit. Some have said that transparency isn't going to help. The argument that I get from a lot of other conservative groups is that we don't want government mandated transparency. There's the concern that, especially from those that would have a detrimental effect from having the transparency of the hospitals and the insurance companies, they've said, well, this will increase costs. We've heard all these arguments. How do you usually respond to that? And I'll leave that as our last question before we move on to the next panel, because I see some of the panelists starting to jump on.
Well, when patients have $8,000 deductibles and it's November, oops, can you hear me? And there's no way that they don't care about the price. So I think that patients need to know cash prices. I'm not saying we shouldn't have insurance paying for employees' health care. That's okay if they want to do that, but they really need to know what we're paying for, and employers need to know where their dollars are going. So that is just blowback. AHIP doesn't want it out there, and they are the ones that are saying it's just going to drive up prices when people see how low others go, or how much more others are getting paid. It just doesn't work that way in a free market.
Can you tell everybody what AHIP means, please?
Oh, American Health Insurance Plans. They're one of the special interests that really are, obviously they're speaking out on behalf of insurers who are resistant to exposing their prices and their negotiated prices. I understand that. It's going to be there's going to be a pain point. It's going to be really hard for people, but I think once everything gets out in the open, sunlight helps everything. Everyone's going to be able to know what we're dealing with. When I go buy a car, I don't begrudge the fact that the dealer gets a profit. I just want to know what what I'm dealing with here. What should this cost be before I drive the car home and then get the bill and it's non-negotiable and non-refundable? I think people need to have the information in hand, and I think Americans want that. In Ohio, there was a law, I don't know if you know this story, but there was a transparency law that was passed unanimously by legislature for price transparency. 100%. When does that happen? 100% of the legislators passed the transparency bill, and the government blocked it because special interests got in there, and it's all tied up in the court. So they're not getting it. The special interests really, really don't want these prices out there. And I'm sorry, there was a part 2 to your question. I got all fired up on that one. What was the second one?
It was, will transparency drive cost up and not down? That's also one of the arguments.
I disagree. I think in a competitive market, and patients can compare quality and outcomes. And there was a comment from one of the questions that isn't outcomes a slippery slope? Doctors don't always have control of the outcomes. I do think in general, if you're looking at how the infection rate is, or if the patients were happy, I think there is something to be said for that. I think everybody needs to be able to look at all of this with a grain of salt and take the information. Consumers are smarter than most lawmakers give them credit for, and be able to take the price information and the outcome information and how convenient it is and how much they like their provider and shop just like they do for a refrigerator. I think it's really important, and I do not think it will drive prices up at all.
Yeah, David, if I can even jump on that, it's a bizarre argument that they make. The argument, if extrapolated to other industries, would be, well, the best way to get a good price on a flat screen TV is to have no idea what you're spending on it. It's a very bizarre argument. And for people who claim that obscuration of the price will work, well, that's what we have right now. And we have the most costly healthcare system that has ever existed in the history of planet Earth. So it's clearly not working.
Oh, Chad, we all know that you just go into Costco and slap your credit card down. We know you don't check price.
Well, when you're made of cash, what can you do?
Well, I was just going to say real fast on it. The reality is that the transparency does force the prices to reach their natural level, because you'll notice, like on a flat screen, there's a point where it doesn't get any cheaper. I mean, the market is figured out between itself, trying to get to a cheaper price, and those providing that service. This is as low as it can go, that I'm still making a reasonable profit. It's all about that level of profit that they're making, that they're working on in the final analysis, because cost is cost regardless. So transparency is critical.
Let me say this, just because we're short on time, and,
Sure.
and I think what you all have said is extremely valuable and a wonderful segue into our next panel discussion. I'm very pleased to have some good friends and industry leaders that will have demonstrated that transparency does lead to lower cost and oftentimes better quality. So guys, thank you so much for your time, your expertise, your passion, and the dedication that you give for patients and physicians every day.
Thanks, David.
Thank you all very much.
Thanks for having us.
David.
All right, I am trying, there we go, okay. All right, David, and thank you, everyone. These panels are very good today. I'm actually learning a lot. All right, so everybody, we're gonna take about a 2-minute break. If you gotta get up, get some coffee, do what you gotta do, and I'll be adding on the next panelist. We have Marty, we have Sean, Dr. Keith Smith.
Hello, it's Marty Makary.
Hey, Dr. Makary. How are you?
Hey, good. Is that David?
This is Brennan here.
Hey, Brandon.
David's here.
Oh, hey, David. Sorry. Let's see. Where did he go?
I'm here, Marty. Good morning, gentlemen.
Hey, good morning.
Keith, you look like you're about to fly a plane.
All right. I believe we got everybody here now.
All right, well, I'll jump off. Hi, Cristin, good morning.
Good morning.
Well, I will be jumping off as Keith will be leading this panel. I think we're waiting on Sean. There's Sean. And very much look forward to your panel. Thank you all for joining us today.
All right, thank you, David.
Thank you.
All right, everyone, this is our next panel on the topic of free market facilities and services. And Dr. Keith Smith is going to be the moderator. So Dr. Keith, I'll turn it over to you. You can introduce yourself and your panel, and you have the screen.
Very good. Thank you. I'm pleased to be asked. What a all-star panel with Dr. Dickerson and Sean Kelly and Dr. Makary, and good to see you all. David, thanks for giving us this opportunity. I believe the theme for today is innovation, which in my mind, and I think the mind of the other panelists, is equivalent to disruption. And I'd like for each of the panelists, starting with you, Cristin, if you don't mind, just tell us a little bit about your background and what you think the most disruptive and innovative facility sort of, or other disruptive modes you see going on in the free market space right now.
Okay, I am a 25-year radiologist. I have been in the cost containment space my entire career. I've always been with multi-specialty groups. And what we're doing now is we're trying to shift about 80%, the appropriate 80% of imaging to outpatient imaging centers rather than the higher cost hospital imaging centers. And that can, over the next 10 years, if we can accomplish that, that's going to save about 8% in total healthcare spend. And that's a huge number. The thing that excites me, new technology in my field, you know, we have the technology to do great diagnostics, to do great screening. New technology to me is getting it out there to people affordably. And the really exciting thing, we all hear about artificial intelligence, and everybody thinks that that's going to replace me. You know, it's going to replace radiologists and it's going to be reading chest x-rays. But what I'm seeing is artificial intelligence applied to existing technology. And this is an example. One of the things that independent imaging centers are struggling with right now is cost containment. And it's because the cost of helium is going up to cool the magnets, cost of labor is going up. It's really a challenge for them. And so what artificial intelligence is, we have two companies right now that are vendor neutral and can take an existing older MRI machine and basically increase the throughput by 3 and make better images, make it a 1.5 Tesla magnet, the images, the equivalent of a 3T. And what they're doing is they're just taking a couple of pulse sequences and recreating the other pulse sequences. So it's really exciting technology, and that's going to enable us to continue to bring down the cost of care in my space.
That's interesting. I've always thought one of the more disruptive things about, Cristin, what you're doing is so many patients enter this disease cesspool that we call our industry in the imaging center. And if they discover there that they actually can obtain affordable imaging, I believe the light goes on in many people's heads that, well, this wasn't the $5,000 MRI I thought I was going to have. And I believe that people wake up and begin to wonder, are there other affordable, high quality options out there? So I've always thought one of the more disruptive things about what you're doing is at least turning that light bulb on, or giving people the opportunity to kind of wake up and at least give that some consideration. Marty, why don't you go next? Tell us about yourself. Not that you need an introduction. Tell us what's going on with you and what your views are about the state of innovation and disruption in this space right now.
Well, thanks, Keith. It's great to be with you, and really cool to be with these other panelists here. Thanks, David, for hosting this. So my interest has been in rebuilding the public trust in American hospitals and in the medical profession. That great public trust, which has an incredible heritage, an amazing heritage that's intertwined with altruism morality, ethics, our great American spirit, ancient tradition of the medical profession of taking care of all of those regardless of their ability to pay. That public trust is now being violated as it's never been violated before with price gouging and predatory billing. So most recently, in response to the comments, which I was very pleased with, from this message of the sort of a compendium of our research over the last 3 years in the book, The Price We Pay, that I wrote and came out last month. What my team has been doing since then is developing measures of billing and pricing quality. We've got measures of cardiac quality. We've got measures of surgical quality. We've got measures of primary care quality. We've got all of these measures, mostly immature, oftentimes inefficient, too many, sometimes more costly to measure than they provide any benefit. And so this entire measurement industrial complex, the good and the bad of it, has been entirely focused on complications of care that are physiologic. And my feeling is that billing quality is medical quality, and financial toxicity is a medical complication. And taking care of a person is taking care of the entire person. As you say best, Keith, and my favorite quote that I often cite from you is, I don't understand how a doctor takes an oath to take care of a patient at a time when they're vulnerable and then ruin their life financially. And so we've developed 6 measures of billing quality that we anticipate, and this is unofficial, but I anticipate that they will be published in one of the top 2 medical journals in the coming months. And they are, number 1, does the provider provide an itemized bill in plain English, not this crazy code language that we've all become enslaved to by the AMA to pay them a licensing fee on every single bill that gets sent and processed. Number 2, does the center provide real prices for common shoppable services upon request, not just posting machine readable prices on their website? Number 3, can patients speak with a hospital representative promptly if they have a concern about their bill? Can their concerns be investigated, and can that hospital close the loop? You would expect that of any car dealer. If you bought an expensive car from them, they should pick up the phone. They should answer your questions after you purchase the car. People deserve better service quality. Number 4, does the hospital sue patients? Do they garnish wages, put liens on homes, or withdraw money from your state income tax return because you cannot pay the bill? I would call these not bad debt. I would call them unaffordable bills as a result of price gouging. And number 5, how do they treat out-of-network patients? We can get our act together to provide master bills that are honest and fair. And number 6, does the hospital charge patients for serious preventable events? The SREs, as defined by the NQF, are extreme things like operating on the wrong side, leaving a sponge in, death of a patient who's ASA class 1. These extreme, what we call never events, should not be on the paid for on the backs of the everyday families and victims of these catastrophes. So these are basic billing principles that we are putting out there as ways that we should measure quality, because quality is not just medical complication rate quality, it's financial complication rate quality. So we met with Leapfrog Group yesterday, and they are embarking on this. And I think we're going to see a lot of traction on ways that we can create really public accountability around pricing and billing.
Yeah, that would be a stamp of quality, sort of like the UL stamp on the bottom of a lamp, that I think every honest facility that wants to not just be a medical advocate for the patient, but a financial advocate of patients would seek. That's very interesting. It'll be fun to follow. Sean, are you with us?
Yes, I am.
Sean, tell us about yourself and what you believe. You sent me a message this morning defining disruption. I'm going to let you run with that.
Okay. Thank you, Keith. And thank you, David, for hosting. Good morning, Cristin. Good morning, Marty. So I think I'm the lone non-MD on this. And I have both my siblings are doctors, so I feel like I understand medicine better than most MBAs. But coming up from a business perspective, I think it's useful for us to define disruption, because I think it means a lot of different things to a lot of different people. So according to the Cambridge Dictionary, disruption is an interruption in the usual way that a system or process or event works. In my humble opinion, it pretty much sums up our movement, what we're doing as individuals, but then also collectively in the FMMA, the Free Market Medical Association. And so a little bit about us, you know, my brother and I both worked in large hospital systems. I saw particularly where a lot of the money was flowing, and I saw that there was no real control on the price increases on the large system facility side. So we knew that if you worked with quality surgeons, that you could make sure that the patient was taken care of in facilities that were both quality and appropriate and cost efficient. Cost efficient meaning an ASA1 is taken care of for a lump and a bump, and an ASC, ambulatory surgery center, versus a hospital. And so we started the business, and of course we were blessed with the opportunity to sit down with you, Keith, back in 2016, and asked you some very important questions, which helped us to avoid some of the potholes that I think have caused a lot of pain for other people getting in this. And we based out of Austin, Texas. We sell directly, just as you do, to self-funded employers. And if you want to talk about disruption, from my perspective, I think the model, and Cristin, the model we've developed is really honed to ensure that the patient gets a quality outcome, because we're here selecting by other means the specialist, but then we're also making sure that they're seeing the most appropriate site of service, so cost is appropriate. And then we're eliminating a whole lot of the complexity and extra cost that the system puts on every single episode of care. But then where I think the disruption that is going to, I think, transform healthcare in this country is on the buyer side. Now, that includes the intermediaries. And I think it bears mentioning innovative intermediaries that really led the charge and done so at their own peril. And that's guys like Jay Kempton, the Kempton Group, Boone Chapman here in Austin, AMPS, and others, and also Apostrophe, I would say, is a new entrant into the TPA or intermediary market that really helps for employers to be able to purchase directly from providers like us, who are providing not only quality, but also at a very competitive cash price.
Hey, Sean.
Yes.
Is there any way you can get closer to your mic? My chat is lighting up with messages that can't hear you very well, and Cristin has some sort of hearing device up close to her head. So
okay, is this better?
We're going to need some emergency well-placed cochlear implants, or I need you closer to your mic.
Can you hear me better now?
Yes.
Okay, sorry. And so I think a lot of the disruption that will occur is both on the enablement side, which is the intermediaries who will allow or provide the enablement both in terms of technology and model for employers who want to get out of the current cartel purchasing methodology and move into a more direct relationship with the healthcare providers who are providing services to their members. And so I think the buyer side is where the real improvements need to occur. because I'll never forget, Keith, the thing you told me in 2016 was, be careful about investing a whole lot of money in the facility at this point. There's not a whole lot of buyers out there. We're all pushing hard to get more. And I think that has happened, but it's still minuscule compared to what the big VUCA networks drive through their purchasing process. I think that if buyers, they get smart, the employers who become smart shoppers, like they have in so many other domains, they work the supply chain. They'll be choosing quality providers who are willing to put their quality out in front, transparent, like we all do. And at the same time, give a firm price for a set of services. I think Marty brought up something important about patients understanding what they're actually purchasing. And from a business perspective, I look at that as, in healthcare, there are very few discernible products. So LASIK is probably one of the best examples. You go in, you get a diagnosis, you have myopia, and LASIK doesn't just mean the operation. It means the entire episode from start to finish, because they're competing in a cash market. Now, in that same way, what we do as bundled providers, or direct contract providers, we do the same thing. Keith, you don't sell a minute of anesthesia time to go with that DME, or to go with that surgery, or to go with that scalpel. You bundle it into products that the patient can understand. They have a diagnosis, and then you have a solution, and that's a well-known treatment that provides that type of outcome that they need. And then you bundle it all into one price so that there are no gotchas, there are no things left off the table. And if there are things left out, it's very clearly stated up front that they're not included and why, but then that information is given to them as soon as that number is known. So it's not a way to gouge. So I think I'll stop right there.
Yeah, and I think you brought up a kind of a subject and a topic that I've discussed many times, and that's sort of the chicken and the egg phenomenon in this industry. As we talk about facilities in particular, and innovation and disruption in facilities, the entrepreneur is always forecasting the future, and the idea that buyers will actually be present to buy whatever the entrepreneur is going to take the risk to create is a critical question and focus. And whenever I talk to employers, large employers, many times they'll say, well, how many people are providing this free market service that's priced this way? And I know people who want to start facilities that are fairly priced and transparently priced, but they wonder, are there any buyers out there who even care? Or are there sufficient buyers out there who care? And this sort of chicken and egg phenomenon, I think, is, do the facilities come into existence, with the hope that the buyers show up? Do the buyers make it very clear that they're sick and tired of following the recommendations of their consultant, perhaps, who's lining his pockets with the advice that he gives to self-funded companies, for instance? And I think that we have to keep that in mind, that's part of the loggerhead of why there are not more facilities providing transparent pricing, is because I think they legitimately scratch their head and wonder, do enough people actually care what it costs, in spite of all their complaining? Because there's plenty of people complaining about how much healthcare costs. The ones complaining the most are the ones that receive the bills that Marty and Cynthia Fisher are trying to address. But most people in the country, by design, I would argue, do not have the sticker shock that would invest the confidence in the entrepreneur to go ahead and depart with capital to create a free market facility. But having said that, and hopefully that spurs some discussion, I agree with Marty that there is a real crisis. There's a real crisis in confidence, and it's well deserved. I think the hospitals the price gouging hospitals that are seen as vicious, mercenary, merciless price gougers. I think that that's well deserved. But is that not an opportunity? I see a hospital system in Oklahoma City, for instance, amongst the several hospital systems here, being able really to distinguish themselves in the marketplace by being fair and honest with patients about pricing. And I would think that if I were running one of these hospitals, I would see that as a market opportunity. So I'd like everybody's opinion on that. I mean, in big cities, in particular, where there are multiple competing hospital systems, do you think that idea that, you know, I'm gonna stick out, I'm gonna not rip people off, and that actually is going to be better for my business? Does that make any sense at all to any of the panelists? Marty, start with you.
That's really the way the free market is supposed to work. Patients should be rewarding good actors and good behaviors. The problem is they're walking into a black box, and as long as patients are picking hospitals based on who's advertising at the NFL stadium and who's got, you know, parking, we don't have a competent marketplace. We do have competition, but it's at the level of advertisements, billboards, and valet. It's not at the level of quality and pricing. That's real value. So I think we need to enable the vehicle for people to be able to make decisions, and that is sort of like nutrition labels. You know, when we wanted nutrition labels, the industry, if you remember, the food industry said, we can't do this, it's impossible, there's too many ingredients, nobody can get this information, and if we do, it'll cost so much, food prices will spike. Well, guess what? None of those predictions were true. We got nutrition labels, and now people shop for food based on nutrition. And companies boast about their low sugar and their nutritional ingredients. So it's not unlike travel websites. You know, if prices, if you think about the price from a flight from where I am, Washington, D.C. to Florida, in 1979, cost $200. Today, it costs about $250. You talk about a stable market where competition has enabled checks on prices. I mean, that's remarkable. You talk about minimal inflation over the course of, 40 years. And travel sites have been that vehicle to enable people to shop. If the airlines billed us after the flight and didn't have to show prices, guess what? They'd be price gouging us left and right. You'd have stories looming in the United States. You'd have not just a bill of the month series at NPR, you'd have a bill of the hour of United Airlines charging somebody $50,000 for a flight from Philadelphia to Chicago, and a surprise bill for $800 for a Coca-Cola. That would be the incompetent marketplace we would have if you had this system where prices were only disclosed at the time of billing. And when patients asked, hey, how much is this going to knock me down? They would be given the standard runaround that hospitals have been giving for 50 years. Look, I don't think personally that we have bad people running American hospitals. I actually think we have good people in a bad system. These are people that have inherited this crazy game, this insane game of artificially inflating prices for the purposes of secret insurance discounts as a part of a rich man's game, where all these special interests are doing quite well except for one, and that's the patient. So rather than, the blame game which we see go around in healthcare, I think we need to look at this system that we've inherited and say, this system could be better, be a leader, do some cool things. I just talked to a hospital CEO in Nashville, and this hospital CEO said, we're going to post our prices on MD Save. We're going to renegotiate our hospital contracts with the doctors groups that come into our hospital to make sure they don't surprise bill. And if they send a separate bill, it's in line with the in-network price. and they provide minimal and transparent discounts to insurance companies. And I thought, here's a step in the right direction. Here's a leader. This hospital should be rewarded over the next hospital that may say price gouge and even engage in predatory billing.
Yeah, and one of the Austrian economic concepts that was so radical that was so disruptive was the idea that the customer is sovereign, and that none of the arguments by the suppliers of a good or a service, none of their concerns should really even be addressed. It's only the consumer that should be the focus. And I think that's part of what people need to keep in mind when they hear some hospital administrator in a $5,000 suit saying, but our costs are so high. As Jay Kempton has said many times, in what other industry are the problems and issues of the seller the problems of the buyer? And the buyer, I agree, needs to be sovereign. I think Cristin has stepped up and has seen the price gouging all around her as an opportunity. I will say we have at the Surgery Center of Oklahoma. Cristin, do you want to comment?
Yeah, I do. And I agree with you, Keith, that one of the biggest problems we have is willing providers. And there are a number of reasons for that. There is the fear factor. But the biggest issue is that doctors don't understand that they're spending 30% of their revenue to collect 70% of what they're contracted to receive from these quote unquote insurance companies. And when they're educated about that, they understand that, we can fairly charge a reference-based pricing or just a flat fee and do so much better and not be subject. I can't tell you how much time I spend arguing against auths, against pre-authorization. There is absolutely, I see no difference in my, when I have an auth in place with a direct contract compared to a one without it. I see no difference in utilization. It's just a hoop that doctors have to jump through that drives up the cost of medicine. And I think one of the biggest issues is, and this is part of the sick system, is that almost 70% of doctors in this country are either subsidized by or employed by a hospital system. That's one of the things that's broken. And the cost of care all the way up throughout the episode of care is at least three times greater. And in a lot of cities, it's 9 times greater in these cities that are dominated by hospital systems like Boston and Pittsburgh. And that drives up the cost of care all the way through somebody's episode of care. And that is just what we have to do is we have to incentivize these people to find the independent doctors, to find the independent imaging centers, give them ready access to this kind of care so that we can change the system.
Yeah, I agree with you. The hospitals owning physicians is a real issue. John Chamberlain, I believe, who's participating, has told me that much of this purchase of physician practices has been fueled by the facility fees that the federal government allows the hospitals to charge, and also the site non-neutrality, where a hospital outpatient department, for instance, bills multiples and collects multiples, even from federal payers, for the same service provided at a facility like mine. Even as the topic of site neutrality is being addressed properly by the federal government, there's some hope and even some sign that hospitals are shedding themselves of the physician practices many of them have bought. I'm old enough, I remember the extreme push back in the 1990s in the early 2000s to ban physician ownership of any facility. And a friend of mine very wryly said, I guess it's okay for hospitals to own doctors, but not for doctors to own hospitals. And of course, this is a throwback for physicians to own facilities. That's the way many, if not most, facilities in the United States, when you look at hospitals, that's how they were founded, was by the physicians who worked there. I'm getting messages, and I think the other panelists are too, about some of what we're discussing. One of the one of the message that I received was with regard to the growth of this movement. And a comment I would like to make, just as in the last panel, they brought up the idea that actually posting prices and price transparency will drive prices up, and how ridiculous that is. I think we can probably all agree on that. We may want to discuss it. The other point the detractors would like to make that I've seen has been led by the liar and idiot Jonathan Gruber from MIT, who's saying even armed with price and quality information, patients will not make the right decision. So, number one, let's not get the information out there. And number two, even if patients have it, they will not know how to use it. The third detracting and distracting comment I think that's made about the innovation and disruption that's occurring, which I found very interesting, is criticism of the lack of participants in this free market movement. And I would say that there are as many people participating in this free market movement as there are, given the obstacles, is truly astonishing. Are there any of those 3 points, Sean, you care to respond to?
Yeah, I'll tell you what, Keith, I completely agree with, I'm very surprised that Marty mentioned a hospital in Nashville that was willing to do some of this stuff for the reason that I think Cristin brought up, and then also you and I have talked about in the past, Keith, is that it is really hard for a facility who receives 95% of their revenue from a couple different sources, and those are big VUCA contracts. And then you're getting that money, it's the beginning point of the dollars coming from an employer, but their intermediary, for all intents and purposes, that's why we call them a payer. They're not paying anything in most sense. They're just passing dollars through. But because of that, everyone knows how important they are. And it's unstated sometimes or stated, but it is very critical to decision making from an entrepreneur to take risk on a facility. Why? Because if you're going to take risk on building a facility that's going to expose prices, there's going to be pressure put on you by the VUCA carriers. They're going to come to you and say, well, those are our patients. They're coming to you from employers that have a network, and they're taking them out of a network, and we're going to challenge you on that. In fact, we're going to cancel our contract with you. For most providers today, with margins where they are, based on what Cristin was saying about the 30% off the top, there's no way that you can let that revenue go today. So it's really hard. The switching costs are incredibly high for existing facilities, and almost impossible right now for an entrepreneur to seriously consider doing a cash-only facility. You know this from your experience. You've been doing this since 2009, I believe, 10 years now, and up until very recently, you still had contracts. It's a hard switch. Now, I do think, though, that the issue around facilities getting into the free market, there needs to be, so facilities have to know their cost as a basis for how they're going to price. And most of them have no idea what the costs are. So I brought an accounting methodology that I had worked with in 2 other previous industries in my career. I brought it to healthcare in 2005. Everybody told me, no, go down the hall, the cost accounting department's down there. And when I got there, I was totally surprised, because it is not what any accountant would call cost accounting. It's the hospital system's lovely little fiction about what things cost that they give to Medicare so that they can increase the amount of money that they get from Medicare. You can imagine how tight those costs are. They don't reflect reality in the least. But I brought time-driven, activity-based costing with me. It didn't work within the hospital system. No one wanted to hear about it. No one thought it was important, because pricing was independent of cost. Now, if you're going to compete in any business based on price. The smartest way to start is to understand your cost and add in a margin and see where that compares with a market price. You might find that there's actually a huge opportunity there to make a good margin and still undercut the existing prevailing market price. And that's where I think we are. We, Keith, Cristin, we all three know what our costs are, you know, to the minute. And therefore, because of that, we can price to whatever purchaser that comes to us any new service. On a daily basis, we have people call and say, well, I didn't see this on your website, Sean. Could you price it for us? Sure, let you talk to our nurse. Get some of the clinical information, 15, 20 minutes later, we've got a bundle put together. Now that it presumes that we had contracts and everything in existence with the specialists, facilities and others that needed to complete the episode of care. But we've got quite a few of those, as you do, Keith. So if somebody calls you today and asks you for some esoteric procedure, you can come up with a bundle pretty quick. Well, it's because you understand your cost. So you're not really taking any risk when you price because you know. Now, hospitals stepping off of the curb into the road. I don't know many hospitals that know their costs. And if they get smart, they will learn that cost. And then they'll be in a much better position. I know that our chief medical officer came to us from Baylor Scott and White. He was chief of orthopedics before he left, Dr. Schultz. And one of the stories he tells is they did bundles, and the only bundles they did were the CJR, the Comprehensive Joint Replacement Bundles for Medicare. And he said when they tried to do another bundle, it took 12 months and they never got to the price because there's so many disparate parties within the system trying to put in their 2 cents about what things cost. So as a starting point, if you're a facility and you're thinking about this, know your cost. Now, what I've learned in the market is there are a lot of surgery centers who do know their costs, and they know them very well because they need to be cost conscious based on their revenues that they get today compared to most of the hospital facilities. But if you have that information as an exercise, just figure out what a bundle costs. You know, do it on a prospective basis, just within your own organization. Figure out what those top 10 procedures are going to cost you. Figure out where all the money is flowing out for each and every of those procedures, and then go out and compare them to what's on the market at the FMMA.org site, the Shop Health tool. And you'll see there are not a whole lot of providers in this country. They're all aggregated there, but they're all over the country. But just take a look at it and see how you compare. I think you'll be surprised at the number of people who've figured out the cost, and your costs are pretty much the same. And then if you can get the information, and I recommend going to the Healthcare Cost Institute's bundle pricing website. It's called guru.com, GUROO.com. And they do, I think, about 80 different care bundles. And they do it based on insurance, employer-sponsored, self-funded insurance payments. So it's allowable. In major markets across the US, it's like 61 million lives, I believe. So you can look at their bundle price and say for a total knee or a total hip, it's around $40,000 in our market. Well, Keith, I know yours is around $15,000. Ours is $19,000. So I think you'll have the same kind of aha. If you're a facility owner or a doctor who's a partner in a facility, I think y'all have that same kind of aha of like, wow, there's a real opportunity for us to compete in this space. Then
Marty, I want to get back to a comment you made about Nashville. I testified before a working group on certificate of need a couple of days ago in Tennessee, and I was shocked that they wanted me to testify, and I think one of the senators that was in the room is actually an employee of HCA. And so I was unhinged in my comments knowing that. And after hearing all their excuses for maintaining certificate of need in Tennessee, and listening to all the pushback, I recommended, in spite of their inviting me to testify before them, I recommended that they maintain their CON, certificate of need, and even toughen it, because that would ensure that even more patients from Tennessee would come to Oklahoma for their surgery. We had a patient come from Vanderbilt about 4 months ago, a family with their 4-year-old, and he needed a circumcision. And they were quoted $21,000 just for the facility fee from Vanderbilt. And our all-in price was $1,800. And these parents were members of a cost-sharing ministry, and they went back to Tennessee and they began to talk. And the word spread, and it was not a good day, I don't imagine, for Vanderbilt. But what I'm coming around to is back to the growth of this movement. I would say that this movement is growing, even though in many ways that it's cloaked. I think the market is pushing even the Baylors and the Vanderbilts, and in my area, Integris, it is pushing them to embrace at least some parts of what's going on, however cloaked they would like to be. I think that hospitals are feeling the pressure when a patient throws down a price for a total joint at a transparently priced facility. Match this, or I'm flying to Austin or Oklahoma City or Bill Grant's place in Virginia or wherever they're going to go. Marty, what's your reaction to that? Do you agree with me that maybe behind the curtain, the market pressure is actually having an effect, the measurement of which may at this point be very difficult?
I do, because what I see is that big hospital systems that were laughing at you, Keith, in your surgery center of Oklahoma, are now frightened. And they're now realizing, hey, we need to get our act together and actually figure out how to itemize a true price for some of these services, because it's no longer a joke. We're now losing business to the Surgery Center of Oklahoma. And that's what I'm seeing in different pockets around the country. That is a great American revolution. And it's sort of a tea party of healthcare, if you will. It's not a partisan endeavor. It's a free market endeavor. And take a look at the hospital that I was referring to, which, by the way, is St. Thomas Hospital. Nashville is a competitive market with some giants there. And this hospital has Healthcare Blue Book come in to make sure their prices are close to reference-based prices. They've renegotiated the contracts with the doctors to ensure there's no money games with surprise billing. They have posted prices now on mdsave.com, which is a Nashville company. There are many sites that are now becoming kayak and Travelocity sites for services. So it's a revolution. We referred earlier to this idea that patients may not use pricing information. And I posted an article that addresses that criticism on the chat. But let's remember, the big money game of the big hospitals is something that really no one knows much about, that we are not talking about as a country, that we need to talk about. And that is a legal clause called an all or nothing provision. And so what's happening in these money game negotiations between hospitals and insurers is that the hospitals say, if you want to do a contract with us, you have to go all or nothing on all of our clinics. So if we are, say, Vanderbilt Medical Center, you have to pay us this standard marked up price or whatever that negotiated price is at every single Vanderbilt center around the world. And they insist on it. Well, guess what that incentivizes? The big Vanderbilt goes and buys some sleepy hospital or some sleepy, fairly priced surgery center or physician group. And all of a sudden now they are part of that all or nothing contracting, where that little low or fairly reasonably priced clinic or physician group is now getting paid at those high Vanderbilt prices. And it's the easiest way to make money in the world. If you're a hospital, buy a clinic, buy a practice, and all of a sudden now you're getting reimbursed at those big academic mega center prices. And so that is the game. And that's why these hospitals are buying up everything. And the reason I say this is not so we all get depressed. It's because it just highlights that the kryptonite for this crazy rich man's money game is price transparency. It disrupts that marketplace. It completely disrupts that marketplace. And so that's why we need to advance these ideas, because when people are looking for care and they see that there's a fair and reasonably priced clinic that provides honest, solid medical care, that is going to steer the patient around these money games.
Yeah, as Gandhi said, first they ignore us, then they laugh at us, then they fight us, then we win. And I think it's playing out very much like that. I know that I'm seeing it in this region. Cristin, I want to get your thoughts about what competition looks like for you in the hospitals that are in areas where you have centers. Are they responding to your pricing as much as they say that is an impossible thing to do?
We don't see that at all in the hospital systems. And in fact, I just reviewed claims for a 10,000 employee school district. And we found 10,000 employees, mind you. We found 600 MRI and CT scan claims that were paid that did not have CPT codes, which is against the law. They can't do that, but they just had hospital codes. This is 600 for a group of 10,000. These were paid out between $2,000 and $39,000. Now you could say, okay, some of these may be sedation cases or complex angiographic cases, not 600 for 10,000. And this was a traditional TPA, so this is one of the BUCA plans, and this is robbery. Think of what this is. These families have a $6,000 out-of-pocket maximum. So this was a financial crisis for 600 families. And it makes me ill. And, I do think I don't think it's a free market when you have no ethics. Free markets don't work. And so there is something going on. I don't believe that most people consciously think about that this is all wrong, what the hospitals are doing. I don't think the administrators consciously do this. I think it's a self-preservation. The system is so broken that they just continue to do the same things they are just to preserve the income streams they have. And I think it's going to take the people like us getting these people out of the hospital systems. That's my whole goal, is to get 80%, 90% of care out of the hospital systems. That's what's going to catch their attention, and that's what's going to create change.
Yeah, and the hospital administrators and the people running these vicious price gouging facilities won't do the right thing because it's the right thing. The people on this panel will do the right thing because it's the right thing. The vicious mercenaries will do the right thing because the market will crush them if they don't. Years ago, you all probably have all heard of Walter Williams, the economist from the Mercatus Center, and my dad asked him a question after a talk, and he said, "Are these legislators ignorant or evil?" Because take your pick. As bad as things go, and most things government, if not everything government gets involved with, are these legislators ignorant or evil? And Walter Williams says both, and they're arrogant. So a real bad combination. And Marty, I'll push back a little bit. I would say, I would maybe agree with you that some hospital administrators are not evil, but I would say that they are thoroughly enjoying and profiting from a system that is broken. They have all the power in the world to push back. And while many of them are not evil, that's my default. Because at this point, with this movement as just astonishingly large and prominent as it is, partly because of the work of people on this panel. There's no way you can claim ignorance. There is just simply no way that a hospital can say anymore, well, you know, we don't know what our costs are. Well, of course they know what their costs are. And so my default position is that these people are taking advantage of a broken system, know exactly what they're doing. What the CEO of a large third-party administrator years ago was summoned to a large hospital here in Oklahoma, and the hospital administrator told the CEO, I'm ready to match Surgery Center of Oklahoma's pricing as long as you exclude them from this game. And the CEO said, well, I think I know how long that price match would last after I agree to it and walk out the door. So I think these people, most of them know exactly what they're doing. I am very anxious to see any and all of them prove that they know what's going on and they want to join us to change it. I don't think we have to mandate that they change it. I think the market is going to crush those who don't come along. We've got, it looks like 10 minutes left. I would like the comments of the three of you on the last issue that popped up in the last panel, and that is on mandating through legislation price transparency. Everybody take about a minute to respond to that. I'll tell my views when we're done. Marty, go ahead.
Well, look, I don't have a lot of faith in the government. Forgive me, I live in the swamp of Washington, D.C. And so, look, I think the best solution is if we get people to demand this. And it doesn't have to be individuals, although that is driving some market change right now. It's also proxy shoppers. It's employers, it's TPAs, it's groups that purchase healthcare on behalf of individuals. If we all demand price transparency, I think we're going to start to see the market reward it because hospitals want business. And so, you know, I couldn't agree with you more on your comments earlier, Keith. We have too many people in healthcare just picking up their paycheck every 2 weeks. And those paychecks get bigger and bigger as the games get, you know, more egregious. And I'm a cancer surgeon. I'm reminded how short life is every day. We've got to speak up. People are getting hammered out there. 50% of Americans have $400 of cash in their savings account or less. People are getting crushed. They don't live like us in the medical establishment. People are getting crushed out there right now. So we've got to speak up and we've got to demand better. When we ask hospitals in the most extreme form of predatory billing to stop suing patients, and we go around the country through our movement, restoringmedicine.org, which is a part of this coalition, we're often told we have to sue patients in order to stay financially solvent by the hospital. You know what? All of the money they collect from garnishing paychecks is less than half of the CEO pay in 1 year. Give me a break. We need some honesty and some ethics back in healthcare.
And I would say that movement is more powerful in pointing out the need for price transparency than anything that could be achieved by mandating it. Sean, do you take a minute and give me your thoughts on mandating price transparency?
So thank you, Keith. So anything involved in healthcare, when we start talking about the government, I think it's important for us to know that the healthcare lobby spends more than all the other lobbies combined. So when I get asked, I live in Austin, Texas, the capital of Texas, where the legislature's in session every 2 years, thankfully just once every 2 years. And when they are, boy, I get lots and lots of people calling and saying, Sean, would you come up and talk? I'm gonna get this bill. I wanna mandate price transparency, quality transparency, et cetera, et cetera. And so far I have rejected all those invitations. And the primary reason is because the cartel lobby will get involved and they will make it about me. They'll make it about something else than the transparency that was necessary for a right functioning free market. And they'll distort it. If it gets passed, the title of the legislation will say something like Price Transparency and Fairness Bill. And you and I both know that what the bill actually will look like, it'll be so distorted as to mean nothing. So I like the price transparency that we're starting to see from the federal level. But because the charge master is broken down into such tiny little incremental supplies and services, it's unintelligible by anyone, including the people at the hospitals. So they can't even put together an episode of care out of that. So I think the price transparency has to go along with the development of service bundles, episode of care bundles that actually are relevant to what patients are seeking. Without that, and in our industry, that's a bundle. Cristin knows somebody calls and they say, I've got this diagnosis, I need this kind of image. She knows exactly what that is. She bundles it up and there's a price. Same thing with you, Keith. Somebody comes to you. You bundle everything in it. You don't just leave out certain things. But that's, in my jargon, or at least from my economics training and my business administration training, that's a product. That's something that a purchaser can look at and compare across different facilities or entities or sellers. And then they can compare cost and quality. But without that, it looks just like noise. The only thing I ask people from government when they say, well, what should we do? The only thing I tell them is you ought to open up all government healthcare purchasing and obligate them to at least get competitive bids where there are participants in markets that are offering bundled surgeries or bundled services.
Yeah, when government asks me what they could do, I tell them to stay home. Cristin, we've got just a little bit of time left. What are your thoughts on mandating price transparency?
I think the best price transparency is actually claims data. And what about government claims? You know, they're employers. What about that claims data? Shouldn't we all have access to that? There's so little bundling going on out there that really pricing transparency. Nobody's going to, if you list a bunch of CPT codes, nobody's going to understand how to bundle those together and come up with a price. I think we're barking up the wrong tree. I think mandating that we get to, as citizens of this country, see claims data and see what's really being paid and what's really, when I show employers what they're really paying for imaging, the light bulb goes on, and the fact that they can drop that by 2/3, comprising about 8% of their total healthcare spend with just a bolt-on plan like vision or dental, making us a preferred provider, the light bulbs go off everywhere. And what they see too is they see their employees struggling and seeing everybody struggling with health care costs. And they want to make it better. They really do. And there are easy ways to do that. And I think rather than mandating, I think just continued education and pressure. We have the much data. I can show you, bundles and bundles of them, and it's there for our taking, and I think that's what we need to focus on, not mandating hospitals. They're going to hide it the best way they can and make it unable to really decipher and understand, just like they have so far.
Thank you. We're almost out of time. I'll give you my thoughts on mandating price transparency. I believe that it's a particularly bad idea because it will afford unscrupulous legislators, which is almost all of them, the opportunity to sell exemptions, basically sell indulgences. It also will provide the big dogs in the room the opportunity to redefine price transparency to suit their needs. When I made these comments to Cynthia Fisher last year at FMMA, she wasn't really sure she agreed with me, and I told her, I said, yeah, the other thing you have to keep in mind is, redefining price transparency will become what is the patient's out of pocket. And she confirmed that was exactly what the thugs, lobbyists in our industry in DC were trying to do, was define price transparency as what is the patient's out of pocket. not actually what does it cost. So I think we have to be very cautious with that idea, acknowledge the extent to which this movement has exploded and continues to, largely due to the work from people who are on this panel. And I would like to thank all of you for your time on this Saturday morning and participating, and David Ballett and everyone who arranged this. Thank you very much. These are all important concepts, and it's good to get this word out.
Thank you, Keith.
Thanks, Keith.
Thank you all. Good to see you all.
You as well.
All right. Thank you, Dr. Keith, and thank you, everybody on the panel. Very informative. And we are approaching our last one on drug pricing and shortages. So everyone, I'm going to do the transition. Thank you all, and give it about a minute break. All right, I think we're missing one person. Dr. C.L. Gray.
This is Ray Page. Can you hear me?
Yes, sir. Loud and clear.
Thank you.
How you doing this morning?
Good.
Good deal. We're waiting for CL. Does anybody, let me see, Terry, have you spoken with him this morning? You're muted, Terry.
CL may be able to phone in at some point.
Okay, there's one call-in listener. I'm not sure that might be him.
It could be. It could be. I got an email from him at the hospital.
Okay. All right. Well, Terry, I will let you take over, and you have the screen. Introduce yourself and your panel and take it from here.
Hi, my name is Terry Wilcox, and today we're going to be talking about drug pricing and shortages with, oh, what just happened to, oh, that was, I'm sorry. With Robert Campbell and Ray Page, both. And we also may or may not have CL Gray join us on the phone, who is also a drug pricing and shortage guru. And I think how I want to open it up is my name is Terry Wilcox. I'm the executive director of Patients Rising and Patients Rising Now. And I'm coming at all of this from a patient perspective. There's a lot of, obviously it's the driving force in healthcare conversation right now is the cost of medicines, drug pricing. It's everywhere. It's in everybody's bill. Everybody on here, I'm based in Washington, D.C. Everyone here feels an enormous amount of pressure to do something. And from where I sit and from my perspective, you know, the patients want something done, but they don't want that done to such an extent that we wake up in 10 years and we're like, what did we do? And we have to redo it again. And I think there's a lot of, there's quite a bit that we can talk about here today. I am not as familiar and not as only from the patient perspective, but I'm going to open it up. Robert, I'm going to kind of let you open it up if you can, and kind of talk about the overarching drug price conversation in kind of layman's terms, hitting on the drug shortages, if you can, if you can start there, and then we'll.
Absolutely. Thank you, Terry. Excuse me. My name is Bob Campbell. I'm a practicing anesthesiologist and pain management physician in Pennsylvania. I've done that for 31 years. And I came to discover really what I would call the secrets of the healthcare supply chain. We know, everyone knows that prescription drugs cost far too much. We also know that hospital medications, whether they be a $525 per liter bag of saline or $1,275 for a dose of isoproterenol, that it is an artificially priced market. And when I came into this, it really comes down to I went to a lot of physician groups and got confused. Then I went to antitrust attorneys, and they gave me the very simple explanation. And the best explanation is the American Antitrust Institute. They say that when you have high prices and low supply, you have an anti-competitive market. And there are two ways that you get an anti-competitive market: either government price controls, or you can have monopolists exerting monopoly power. And that's really what we have. But this is a little different kind of monopoly. In fact, they call it a monopsony. And we've talked a lot about Vanderbilt University. Actually, Vanderbilt has a course on this, monopsony law, and they use the healthcare supply chain as the topic matter for their course. So what you have is you have a buyer's monopoly. That's a middle market monopoly. So as opposed to one company, which we think of commonly as one company cornering the market on a given product and keeping competitors at bay. And there are examples of that, like for instance, voting machines are made by one company. They charge too much, and anyone else who tries to make voting machines, they pay legislators and they sue them and they keep competitors away. That's a classic monopoly. This is a buyer's monopoly, too few buyers. So when you have a prescription drug, 95% of prescription drugs go through 3 pharmacy benefit managers who negotiate the contracts. And we have to know a little bit about some vocabulary. So PBMs, there's 3 of them. CVS Health is the biggest, Express Scripts number 2, Optum RX number 3. So all prescriptions go through contracts that are written by them. They control access to the market, tiering of the market. They actually determine the price that you pay at your pharmacy. And that price currently is about 47% of the cost of that goes to what they call rebates, which are legalized kickbacks. So that's the prescription drug pricing dilemma, is you have inserted an extra layer of middlemen, the PBMs, and they have a very special power. They have what's called a safe harbor, anti-kickback safe harbor. We call it the GPO PBM anti-kickback safe harbor, which exempts them from all federal racketeering laws. So what they are able to do is essentially sell tiering, sell access. So an EpiPen, if I make an EpiPen at a lower price, higher quality, I can't get to the patient unless I pay a bigger kickback than Mylan is paying. And then I'll just finish with, so that you get the whole architecture. That's the PBMs control the entire prescription drug market. The GPOs, group purchasing organizations, are again 4. There's the big 4 as opposed to the big 3. They control all hospital and nursing home purchasing, at least 90% of that. The big 4 GPOs are Vizient, which alone controls 50% of all hospital purchasing, Premier, Health Trust, and Intalere. So those are the big 4 GPOs. They do the same thing on the hospital side. So when a bottle of nitroglycerin costs $1,000 instead of $10, or saline $5.25 instead of $5, there is these secret contracts with hidden rebates, and no one knows about it. It's because they're private contracts. And that's one of the things about transparency. These GPO PBM contracts are very highly guarded. And if we try to get transparency laws passed, they're going to claim constitutionally protected privacy rights for private contracts. But the GPO PBM safe harbor for kickbacks is the fundamental heart of the medical industrial complex. So the PBM side, we think it's about $150 billion in rebates. And the GPO side, we think it is about $100 billion in rebates. So you're talking $250 billion in legalized kickbacks. Wow. It's anti-competitive, high prices are built in. The higher the list price, all the rebates are a percentage of list price. So if I can tier a drug that's a higher cost drug, there's incentives to do that because everyone makes more money.
Wow, what a system. So, Dr. Page, Ray, so first of all, please introduce yourself and kind of give your overview of this situation, how you see it from your day to day.
Yeah, so this is Ray Page, and I'm a medical oncologist that's been practicing for about 25 years in Fort Worth, Texas, as a private community oncologist where I treat all types of cancers. And every year I see the challenges of affordable delivery of care becoming greater and greater. And one of the greatest challenges is just the relentless escalation of drug prices. And in my independent practice this year, 79% of my entire budget is just in the purchasing of the drugs to give to cancer patients. This has risen every year to where most small independent practices are no longer able to harbor the risk of buying such expensive drugs and stay positive in their revenue cycles. This has resulted, as documented in the impact studies of the Community Oncology Alliance, that in the past decade, over 1,600 community oncology clinics or practices have closed, been acquired by hospitals, merged, or are reporting financial struggles. And this migration of practices to major hospitals and corporate-based systems are proven to be far more expensive cancer care delivery systems as compared to independent oncology practices. And as oncologists, we unfortunately have been involved with providing some of the most expensive treatments in healthcare. And the majority of the top 20 most expensive drugs are in the oncology space. But I think we all have to agree that physicians, we're not the ones setting the entry price of these drugs on the market. Yet we often seem to be targeted as the culprits. And the high cost of many of the cancer drugs may be attributable to their true pharmacologic complexity and the fact that they're first in class in targeted therapy, and there is rigorous safety analysis since these drugs are potentially deadly. But seeing a year-over-year 20% increase in the entry price of new drugs is just untenable as compared to a general year-over-year GDP growth of about 3%. So most all cancer centers across the country have their own retail pharmacies, whether or not they're an academic center or a hospital-based practice or an independent community practice like mine. But the impact of the PBMs affecting the delivery of cancer care, no matter how small or great of your center is substantial. And so more and more cancer centers whether we're big or small, are trying to get specialty pharmacy status to be able to combat some of the PBM tactics of, quote, out of network, direct and indirect remuneration fees, which for my practice is going to be about $1 million this year that I'm paying back to the PBMs, rebate clawbacks and gag clauses. And in general, cancer drugs not only have the risk of substantial physical toxicities that need close pharmacy management, but they also have tremendous financial toxicities for the patients that we can help manage with our own pharmacy staff, in which the resources do not exist with the PBMs. So it's highly preferable that cancer patients get their prescriptions through a highly trained oncology trained pharmacist at our cancer centers to where they have full access to the patient's electronic health records and drug list and who know them personally. And our pharmacy staff has resources to educate the patients and work on foundation and financial issues, and to be immediately available by name to triage further questions and symptoms. And this is what's best for the patients. Unfortunately, the PBMs are redirecting our treatments from our pharmacies to theirs, and they're trolling for our patients. I can tell you that in recent years, we've seen the PBMs just consume this space, and we've seen the erosion of our oral anti-cancer prescription management through our own pharmacies by approximately 10% per year. So we've got from 30 to 40 to 50 to now 60% of our oral cancer drugs that we prescribe are now directed through the PBMs. And 70% of those are concentrated, as mentioned previously, in basically 4 of these behemoth pharmacies, Aetna and Cigna, Aetna CVS, Cigna Express Scripts, Walgreens, and United Optum. And just in the specialty pharmacy industry, that's a $146 billion industry that's being run through the PBMs. And so part of this perversity that arises with these PBMs is that they are completely vertically integrated to where they now involve the sponsor, the insurer, the pharmacy, and they have clinics and physicians that are under their employment. So they have complete control of the patients and the flow of all their prescriptions. And they make these transactional relationships between all these entities and drug manufacturers and distributors and providers to where they generate enormous profits for the management of these drugs. And yet none of these profits are ever passed on to the patients. And this can be harmful to cancer patients. And the Community Oncology Alliance also has a website that shows numerous of these horror stories. So,
yeah, I'm very familiar with the Community Oncology Alliance and the work they do and the website, and the horror story website does have a lot of great information. I want to come back to you, Dr. Page, in just a minute, because I kind of want to talk to you a little bit about 340B and that effect on things. I think you might have a little insight with that, given your role as a community practice oncologist. I know that Dr. Gray is on the phone. Dr. Gray, can you hear us? Can we hear you?
Yeah, I'm in the middle of ICU rounds, but so I only have my phone. I don't have video, but
I understand. I understand. I just wanted to, I saw that you were on. So given in the tenuous nature of where you are and that you are actually working, I wanted to give you a chance to introduce yourself and sort of talk about your perspective on drug pricing and drug shortages and all of that before we lead into some more specific areas of the topic.
Yeah. Well, thanks so much for having me on, and thanks for everybody for making time for this. It's an incredibly important subject, and with Free2Care, just for putting all this together. I was going to just spend a couple minutes talking about the big picture. I used to be an electrical engineer. Now I do hospital medicine, critical care, and it really helped me to understand sort of why the system works like it does and how we got here, because that tells us a lot about how to change things and fix it and moving forward. And it took me, I really didn't understand any of this until I started talking to Bob Campbell, must be a couple of years ago now. And it took me probably 3 months just to get my head around what was really happening. And what helped me the most was to understand how we got here. And this really started back in the early 1900s. In like 1910, in New York, at that stage, transportation was difficult, communication was difficult. So hospitals were trying to figure out how do we decrease our costs. So they got together and put together these things called group purchasing organizations, GPOs, same things we have now, where the hospitals would get together and buy in bulk at a discount, and they'd pay a small fee to the GPO. And in return for that fee, they would get discounts on all their drugs because there's free market competition. Same thing for like Costco or Sam's Club. And that worked well for about, 75 years, up until 1987. And then there was some legislation passed where it inverted the economics of the healthcare supply chain. And the argument was there were a lot of hospitals sort of making marginal profits. Pharmaceuticals were making tremendous profits. So they said, let's shift this expense from the hospital industry to the pharmaceutical industry. So then the manufacturers would pay this surcharge to get their drugs to market instead of the hospitals paying for cheaper drugs. Well, then with consolidation of the GPOs, where there were initially scores of them, it's now limited to 4. And as they consolidated the market, they gained control over the healthcare supply chain. So a manufacturer would have to go through one of these 4 companies to get their drug to market. It was supposed to be, in that 1987 statute, supposed to be tightly regulated. But as it turns out, nobody looked. So it became essentially a kickback system, or essentially legalized racketeering. So to get a drug to market, the manufacturer had to pay a fee. And Bob, perhaps you can hop in with your example of the EpiPen was sole source contracting. So if you have a sole source contract like Mylan does for the EpiPen, that means you can charge as much as you want. And you know, because the people controlling the supply chain won't let any competition come in, you can essentially charge $700 for a $70 product, and people have to buy it because of a problem with a third-party payer. It's covered through insurance rather than out-of-pocket costs. So it drives up insurance rates. Well, so much of this money has been acquired by these middlemen. As was mentioned earlier, CVS Caremark actually purchased Aetna in December of 2017 for $69 billion. This is the equivalent, essentially, of a company that drives trucks purchasing Coca-Cola or Pepsi. So it's just crazy how much money is involved in this. The challenge there is that we're seeing, as mentioned earlier, we're seeing a vertical consolidation of the healthcare system. So now you have one of these distributors, a GPO, or in this case, it's a PBM, the Caremark, purchasing an insurance company. They also have minute clinics being staffed by oftentimes nurse practitioners. So the insurer can push their patients to the minute clinic. CVS can push their patients to CVS pharmacies. And it's becoming a tremendously powerful system. I actually spoke to Mark Meadows about this about 2 years ago, and he said he would fight to change this, and actually drafted a 2-page piece of legislation to change this fundamental statute from 1987. So, but there was so much political pressure applied, he was never able to actually introduce the bill. Because what they threatened him with, saying, if you take care or take away all these kickbacks of the healthcare supply chain, now that we own the insurance companies, we're going to raise insurance rates and blame you. Basically, take you out of office if you threaten our money. And this is somewhere around $250 billion a year. So, and just one last piece of history, the link between the GPO, the Group Purchasing Organization, and the PBM, the Pharmacy Benefit Manager, is in 1991. There is administrative extension of the safe harbor protection from the 1987 statute. It was administratively extended to from the inpatient healthcare supply chain, the hospitals, to the outpatient healthcare supply chain. So the protections the GPOs had by statute given in 1987 were extended administratively to the PBMs in 1991. That makes it slightly easier to go after the PBMs because they have administrative protection. However, they still have a tremendous amount of money. Dr. Campbell and I put together a white paper back in January of 2018 that actually found its way to the president. And President Trump actually started to change administratively some of the GPO protections. Of course, as Senator Cassidy said, the empire will strike back, and they did, forcing Trump to pull back on those administrative changes. But we still have access. We're working with the Republican Study Committee, working with several other groups inside DC, including the White House, to continue to push this issue. But essentially the fix is what that 2-page bill that Congressman Meadow wrote, that if we can take away these safe harbor protections given in 1987 to the GPOs, it'll necessarily remove the safe harbor protections of the PBMs and return free market competition to the system. So
Right.
In a handful of minutes, that's my best summary of what's happening.
Thank you very much, Dr. Gray. We really appreciate that. I think you gave us a good segue into where we really need to go with this panel over the next half hour or so that we have, which is, you talked about, the administration was, they got the middleman thing, they were going down that road and side railed because of, the same reason that Mark Meadows was, which was, threats of raising premiums and things like that. So now we're sitting at the crossroads of a demand for something to be done with drug pricing. And we've got this Grassley Wyden bill in the Senate. And we've got this horrific thing in the House that I can't even begin to, comprehend how bad it is. So what are your thoughts on those? I mean, besides just let's kill them and never see them, as not necessarily this. I think the Senate has much more workable parts. And I say from a patient advocate perspective that really the only thing that we can support at Patients Rising in the House bill is the lowering of patients, putting a cap on patient out-of-pocket costs, which we've been calling for quite some time. It's all the other things that go along with it that are, concerning. Specifically with just last week, it was like, oh, well, it's gonna be okay if we just have 8 to 15 fewer new medicines a year, and they're all going to be Me Too medicines. And I'm like, do we really know that they're just going to be Me Too drugs? We don't know that. We don't have that kind of crystal ball. And so, anyway, let's start with you again, Bob. What is your take on what we have as drug pricing solutions right now in Washington?
Right. Thanks. And okay, so we had the president, of course, who made it a campaign commitment to lower the price of prescription drugs, and his PBM rule, which he introduced in May, has been withdrawn. That would have really attacked the middlemen. The PBM specifically, because that's all that he had authority to do. So that's kind of off the table. Although when I was going through Senate offices in February before the PBM rule was released, all the senators were like, well, let's just let the president tackle this. Let's just let the president tackle this. So pulling that bill was, the sausage of government. It's sausage making. It's unpredictable, and you don't know what goes in, you don't know what comes out until it actually happens. So now we're stuck with an election year cycle, and we have the Senate and the House wanting to do something and at least be able to tell constituents they're doing something. So there's three major bills. House Bill 3, that's Nancy Pelosi's bill. That is, by my estimation, really a far reach price control. It is a big step towards a government single payer. It would never get through the Senate. But it does allow House members to say, I'm for House Bill 3. It's easy to remember, House Bill 3. I don't think that's going anywhere. Then there's Senate Bill 2543, which is the Grassley Wyden bill. Now that is kind of Pelosi light. It only involves government programs. It's really geared at protecting Medicare Part D participants and selecting out drugs that are egregious in price hikes and setting some kind of annual inflationary cap. I don't think that's going to pass either. So that even in the Senate. But what I think would perhaps happen, and maybe not, but perhaps, is bipartisan wise, there is an effort to at least Medicare Part D premiums and Medicare Part D copays create some kind of cap, whether that be $2,000, $2,800, $3,500. Where they pay for that is, of course, just government 101. They just, it's a deficit issue. But I think that's the only thing that could really be actionable. Now, there is a bill, which I don't think would go anywhere, but needs to be mentioned. And that is Senate Bill 657. So that is Senator Braun from Indiana, the junior senator. And so the PBM rule was eliminating kickbacks, PBM kickbacks in Medicare and Medicaid programs. That was Trump's rule. And we've said that's been sidelined. We had a meeting with Secretary Azar on Monday, and he's loath to revisit that, although after the election, who knows. in general, I guess when these people have a defeat, they don't like to just keep going back to that well. It's kind of humiliating. So the president is probably not going to attack the middleman. The Braun bill is the Trump rule extended to all contracts. In other words, it just simply gets rid of all PBM rebates. It is more powerful. The Trump rule would have gotten rid of $50 billion in kickbacks. The Braun bill, maybe 100 billion, maybe 150 billion, in that range. It won't go anywhere, but it is a venue and a talking point for airing this material. So very little is going to get done, but awareness, physicians becoming educated on this is only going to help. And I will say, not to be a rumor, a gossip mill, but for actionable information in the future, after the Trump bill, the Trump rule was rescinded, GPOs and PBMs, they had kind of been on good behavior, and their contracts were, that was the most threatening thing that they've ever experienced in their existence. And since that was rescinded, we now have GPOs and PBMs being very aggressive with sole source contracts. And this is from industry insiders. And I'm pretty sure that within the next 90 days, there's going to be headline material on both sides of the supply chain. So the PBMs, you're going to have two pharmacy companies who are going to have an open battle. And on the GPO side, you're going to have two medical device companies. They're going to have an open battle. And why is that? So pharmacy companies hate PBMs, but they love PBMs because I have to pay a kickback, but it makes my business model so much simpler. Usually they work out an arrangement like with propofol. For instance, there's two companies that make it. It's a 70-30 market split. Everybody keeps their factories running and nobody is allowed to enter the market. But sometimes if you get greedy, you want to get the whole deal. And then you disadvantage another company and then they don't like that. Usually there's gentlemen's agreements, but if they can't work it out, we could have some headline material. And it's going to be a good idea for physicians and patients to understand the ABCs of the healthcare supply chain so that when media outlets come and say, hey, what do you think about the price of this drug that has been brought out in the headlines, that we can say it costs way too much and this is why, and there is a simple solution. Braun Senate Bill 657.
No, I mean, that's absolutely true. There's an enormous amount of it's very easy. I understand the pressure actually from the patient side of things and just sort of knowing the messaging that patients are hearing in the media and other places. Sometimes they don't know who to be mad at, exactly, especially if they're a patient who's really waiting for innovation. They're waiting for treatments. They've got something, they're on a clinical trial for something. There's a lot of research happening in an area where they are in need of something to help them or help some member of their family. But it's like drug prices are too high, drug prices are too high. And now we started to make some headway before this was rescinded with really educating patients on who a PBM is and what they do and why your insulin prices go up and what contracting is and, why certain biosimilars aren't able to enter the market because the contracting for the name brand is, there's still single source contracting. I mean, there's all sorts of really complicated things that honestly, I wish patients didn't really have to understand. Right. That shouldn't be their job to have to understand that. But my real true feeling about that is that if they don't start to understand it, we're going to go down a river, or go down a path that we're going to regret. To me, 8 to 15 fewer drugs. I know Pelosi's bill's not going anywhere, but the thought, that I got a call last week from Stat, and the reporter on the phone, he says to me, basically, he's proud of the Democrats for actually admitting that they were, that innovation was going to suffer a little bit, but they thought it was only going to be Me Too drugs. And I'm like, proud of them. You're proud of it, but you're proud to say, oh, we're going to have only maybe 100 to 150 fewer drugs in the next decade. Well, that may be okay if you're not sick, but if you're waiting for it, you just don't know. And so there's so many complicated aspects to this that patients need to understand. And we're working really hard to try to figure out really concrete, interesting ways of getting the message to them that's not overwhelming, like we're talking about here. This is a little bit high level, kind of could be overwhelming to the average patient conversation. And I'm going to make it even more overwhelming by moving over to Dr. Page to talk a little bit about something that's also, and this has really affected, I think, your industry, the oncologists, community practices, especially over the past decade or so. Because when I got into patient advocacy, I started in oncology, and 85% of cancer care took place in the community setting. I know it's not that number anymore, not even close. It's significantly dropped from that number. And I think it's like, what is it, around 70 now, Dr. Page? Is in that region?
It's even closer down to 50%.
Oh, wow. It's even lower than that. Okay. Wow. So it's devastated even more than I thought. There is something that I just want to touch on a little bit, and I know you can speak to this, called 340B. And I speak to this because part of this 340B, bringing things back into the hospitals, and I know when the 340B program started, it was a program that started with good intentions. There were roughly 500 and something hospitals that qualified for these lower cost medicines. And just to understand, 340B is a program where hospitals or clinics or whoever qualifies as a 340B outlet can purchase medicines for much, much, much cheaper discounts. But what's happened is now that number, which slowly kind of stayed in the 550-ish range for, the first 10 years or 5 years or however, the first part of its tenure, it didn't grow. But then I think right around the time right before Obamacare passed, or around that time, 2007, 2008, now you look at 2000, now where we are today, it's like well over 2,000, hospitals are now qualified as 340B hospitals. Some I think are in areas like Beverly Hills or something. They're like in really areas where you wouldn't really expect there to be a 340B qualifying hospital. So can you speak a little bit to that, about how that has affected specifically your industry, and from your perspective? I think you would have some good insight there.
Yeah, absolutely. So again, as you mentioned, 340B, and I apologize if my sound is breaking up. I heard it might be breaking up, so I'm sorry about that. But 340B is a drug discount program that came through as Section 340B of law in the mid-1990s. And as you said, at that time, it was with good intentions. And the purpose was to use specific qualifying hospitals that are what we call DSH hospitals, or disproportionate share hospitals, this stage of underserved and underpaying patients. If you meet the calculus and the equation for that, you can qualify as a disproportionate share hospital. And then there's a few other entities out there also that can qualify, but it's basically a hospital-based qualification. And as a result of that, a way to help shore up programs in those hospitals was to force drug discounts on purchasing of drugs. And so back in the 1990s, not a big deal. We didn't have super mega expensive drugs like chemotherapy drugs are nowadays. And so you had a handful of these hospitals that truly had need and could benefit from the drug purchasing advantages. And so, for example, when we talk about drug purchasing for cancer drugs, we have a buy and bill that's based on an average sales price. And so generally out there in the community for community oncology, there's a formula that came about with the Medicare Modernization Act of 2003 to where average wholesale price of drugs went to average sales price plus 6%. So you got a 6% margin on your drug. And then we had sequestration, and that dropped that down to 4.3%. So we have a 4.3% margin on the drugs that we buy and bill. But for the disproportionate share hospitals that qualify for 340B, they get upwards of an additional 40% discount. So if you're, have a $100 drug, they're able to purchase that drug for $60, and they can use that $40, that 40% to support their hospital in whatever way that they want. The problem with the hospitals in 340B is none of that's transparent. And there's mega bucks that come into the hospital systems with regards to that, because in recent years, as you see, the cost of cancer drugs and many other therapies have just gone exponential. So it strongly encourages hospitals to acquire and suck up every oncologist in the community that they can, or their own, because for every full 1 FTE medical oncologist that's out there, a hospital will gain about $2 million per oncologist a year just off of 340B drug margins. And it's not transparent where all those dollars are going, but there sure is a lot of marble on the walls and new buildings going up at the hospitals, and the CEOs seem to be getting compensated quite well. So I'm not sure where those services are. And again, some of the perversities of the 340B is that you have a qualifying hospital that's in the inner city that qualifies for those resources, but through these hospital networks that go out to the suburbs, you do have 340B qualifying infusion centers and cancer centers that are in the Beverly Hills and the expensive suburbs that are able to get that preferred pricing that again goes back to that whole hospital system and network. So there's a major site neutrality issue there. We thought earlier this year that we had part of that solved when we had the ASP for the 340B hospital systems to go to a minus 22.5% to help neutralize and create some site neutrality there, but that recently got overturned. So we're kind of back to square one, which from a community oncology perspective is frustrating because it is hard to compete with these hospital systems that are trying to crush the community oncologist, and 340B is one of those mechanisms.
Yeah, and I think that COA has done a really fantastic job at sort of highlighting some of the stories. If, as a patient organization, we are definitely opposed to 340B as it stands right now. It's often hard for me to explain this concept of what 340B does and how it affects you as a patient, because it is so not transparent and not understood. One of the ways that I often explain it is, okay, your hospital can buy the drug you need at a steeply discounted price, but then go and charge your private insurance or Medicare or anybody else at the full price that they're allowed to charge, whatever deal has been made at the list price. And there's all this sort of ambiguity in between that's, kind of, and it is causing, to some extent, it must be causing, because for the pharmaceutical industry is sending out more and more drugs at this really steep discount rate. It must, you always say that you're going to see it go up here if it goes down here. If you're paying less here, it's going to go up over there. And I think that's probably a part of it. I'm certainly not saying that's all of it.
For example, hospitals very much want my practice, with 20 doctors. So if you just look at the 340B margin, if they could take my practice in to their employment, that's $40 million a year that they would make off of our 340B drug prescribing. Where that $40 million would go from our practice, I don't know. Again, it's being used within the hospital system somewhere.
Wow, that's well, thank you for that explanation. I know that I think it looks like we still have CL on the phone. So I kind of want to touch, since you're at work, you're at a hospital. Dr. Gray, can you speak a little bit to how drug shortages are affecting hospitals? I mean, I know it's really common, oftentimes really common drugs. These are generics oftentimes, the drug shortages. Am I correct about that?
Yes, yeah. We have a computer actually up in the physician lounge that routinely kind of scrolls through the current drug shortages. And sometimes we've been out of IV cardizem that we use for folks with AFib, and just a lot of common medications like bags of normal saline. We were out of 1 liter normal saline bags. So, and that should just absolutely never happen in a true free market. And a lot of times when I'm up in DC, I get pushback saying, no, this really isn't the case, and these middlemen actually help the system. But they're never able to explain why, if the healthcare supply chain is functional, that we're short of salt water. I mean, that just shouldn't happen in the United States.
That doesn't even make sense.
No, not at all. Well, it makes sense when you think about the money involved.
Right. I mean, it does. It makes sense. I mean, knowing what you know, but I mean, to the average person, for you to hear that we're out of saline.
Oh yeah, that part. Yeah, I was talking about what makes sense is when you look at the money involved, and
Right.
how it flows back to help fund political campaigns. It makes a lot of sense why the politicians are loath to take this on.
Right. So as I think we've got roughly, before we open up to any questions that we have a few minutes left. You know, from where we sit on the patient side of things, and I talk about this all the time, drug prices are too high, drug prices are too high. That's what everyone says. And I want to talk a little bit about two policies that are really thrown about that, you know, and just to kind of get your take. And again, I'll go back to you, Dr. Campbell. What are your thoughts on the things that are very prominent in the bill that people seem to think are popular? They sound reasonable, but at the end of the day, even if we did that, is it really going to help? And one of them is negotiating with Medicare. That's one of the big ones. I guess we could negotiate with Medicare, but what would that actually do to the average patient's drug bill?
Well, I think, you know, Washington is really big on what I call fake solutions for real problems, because they need something simple that they can say on the stump. And I think it's just a classic example. The best way to lower prices is to reintroduce elements of free market competition. And there's so many opportunities here, there, and everywhere. You know, the 340B program is a classic example of a well-intentioned government program, which was a bunch of, you know, a consultant, a group of consultants kind of emerged, a cottage industry, and they kind of went to figure out ways for hospitals to gain control of that, and then to literally weaponize it against oncologists, because hospitals benefit from those oncology patients being treated in the hospital because they earn so much more money. So the 340B program has been turned into an inflationary element to the budget. It goes beyond healthcare to the whole federal budget. And it's just a classic example of how these programs, the medical industrial complex, repurposes things. So if you had Medicare, if you had single payer negotiations, the thing that the safe harbor does, and also that would do, is stifles innovation, because you get to where you're no longer able to have a vibrant marketplace that newer, better drugs, newer, better devices get a chance to get to the marketplace. And I just don't see that these swamp solutions are going to be in favor of the patient, getting lower cost and higher quality. And it all comes down to awareness. And like you've said, Terry, it is so hard to make this simple. We do have a 4-minute video, which maybe Citizen Health would make available. I don't know if they can even run it if they want to, but President Trump, one of the things in his Rose Garden speech, he went off the teleprompter one time and he said, we are very much eliminating the middlemen. The middlemen became very, very rich, right? Whoever these middlemen are, and a lot of people have never even figured it out, but we're going to make it so they're not so rich anymore. And so he has a way of speaking very plainly. And in some ways, that's what we have to do. We can get wonky about 340B, and lawmakers have been talking about this for 8 years now. How do we fix this so it serves the underprivileged people in underserved communities, and it doesn't bankrupt, our budget? And as long as you have the medical industrial complex weaponizing it and using it for their own purposes, that's going to happen. So I wish I had an easier solution, but Terry, it's going to take a lot of education and awareness about what works for real, not the fake solutions.
I understand. Actually, Dr. Page, I have 2 questions directed for you. So I'm gonna put those out to you now. One of them is, Dr. Page, one of the big PBMs is Optum. Do they own a large number of oncology practices, and how does this impact patients and costs? Is that?
So Optum has bought a lot of practices. I am not sure if they have bought a lot of oncology practices. Not sure about that. In general, and not being on the inside of Optum and working for Optum, I'm not sure, but I'm sure that the practices would certainly be beholden to certain formularies, restricted formularies. But I'd be hopeful that if there's oncologists that are trying to practice value-based care and getting the right drug to the right patient at the right time.
Gotcha. And this one, another question for you is, have you ever been denied a reimbursement after you've already administered chemotherapy?
You know, that's happened on occasion. And one thing that we've kind of learned, and we tell our billing office, is that, you know, pre-authorization still does not mean assurance of payment. So we can get pre-authorizations and approval to start a therapy, and we buy the drug, put it in the vein of the patient, give it to the patient, and then down the road, the insurance will come back and deny that. And obviously that's a killer for us, because we've bought potentially tens and thousands of dollars worth of drug that we've given to the patient that the insurance is now denying. Now, fortunately, that rarely happens, but it does happen. But when you have an independent practice like mine, where margins are narrow, you have a few of those kind of things. If you have a few errors, a few, pre-authorizations that ultimately retrospectively get denied and all, it only takes a handful of those to take us underwater and actually kill our practice.
Yeah, I can remember my father in Denver. He was the practice administrator for a practice, and I've heard some real horror stories around that issue. Actually, he's retired now, but back in the day, it was those are very expensive drugs. You don't want to be on the hook for them. Before we close out here, I think we have about 9 minutes until the conference is closing for day 2. I kind of want to see, I would like to touch on, we have a lot at stake as we move forward in this. And it's sometimes my heart sinks a little bit when you hear, oh, they've been working on trying to fix 340B for 8 years. Why does anything take 8 years? Like, why does it take 8 years to figure this out? I mean, why does it take, and it's because of the maze of how our system works, which in many ways we're grateful for, because then things like HR3 don't just, get plowed through. But I know many of you will say, but Obamacare got plowed through, and it did. I'm going to talk to you, Dr. Gray, before you sign off. Let's just talk about what is one thing, if you want patients, and I'm going to put this to all three of you, what is one thing that you would want patients and lawmakers and other doctors to know and think about as far as getting active and involved? And I know we're supposed to just talk about drug pricing, but I am of the belief as an advocate that none of this is ever going to change if we don't have real patients and real people and real districts in front of people who are making decisions. So if you had one thing to say to, in this case, I'll say doctors or any of your patients who might be affected by, the high cost of drugs, the lack of being able to have medicines, not being able to go to the doctor they want to go to, what would your advice be, or what would you say?
Yeah, I'll start and keep this short so the other two have a chance to hop in, but awareness and the ability to work together. Just a couple quick examples. I've been working with the Republican Study Committee as they prepared to release this bill, as has David and many others. They're actually very interested in this issue of the middlemen and the safe harbor law. They're planning more of a phased rollout that's not in their phase 1, but we have their ear. There's people inside the White House that are interested. And we've recently partnered with a network of 250,000 business owners through the Job Creators Network. And Physicians for Reform, my group has been working with them doing market research for the past 3 or 4 months. And now they want to work with as many physician organizations and patient networks as possible to tell the story. And fortunately, we've been able to keep repeal of the safe harbor law, the original 87 statute, as the #1 policy point in our stepwise approach to reworking healthcare. So if there's anybody on this call or any groups or networks that want to work alongside of us, what David Blatt has done with Free2Care and the other organizations here has been fantastic. And my last 2 sentences will be, when I first met Bob Campbell, he felt like he was a voice in the wilderness on this thing. And if over the last 2 years, you look at the level of awareness and the changes that we have affected, essentially this network, this group of people working together, we have made a tremendous impact. And if we continue to work together and broaden our reach, I think we can actually win on this issue, because we're right, and patients hurt too much, and we just have to mobilize our patients.
I absolutely agree with you. I couldn't agree with you more. And I am so glad that Dr. Campbell is not alone in the wilderness anymore. I count myself as one of the people who are way smarter today than I was even 3 months ago. So I am always grateful for his knowledge. So with that said, Dr. Campbell, what are your thoughts on this? What are your thoughts on mobilizing? And
yeah, I think we have to make it a kitchen table discussion. So I think all physicians, and we have 37,000 in Free2Care now, we need to be able to have a 5-minute discussion about how this system works. And we have a 4-minute video, which has been distributed. It's an animated video. And on the bottom of that are 11 links that are kind of a sampler across the spectrum of GPOs and PBMs, how it works, that have been published in newspapers and journals. I think all physicians should watch that 4-minute video and read those 11 links. That's your primer. And then if you can talk about it for 3 minutes, you're better than 99% of people in America. So what CL said is so true, and that conversational awareness. The second piece that I would say is, we have the Braun bill, and we have the bill which is not introduced, which is our original bill, which goes back a long ways, but Ensuring Competition in Hospital Purchasing Act. We have a big advantage in that there is just one safe harbor that both of these supply chain middlemen rely upon 100%. As I say, they're both in the same little rowboat. And so they're in the one safe harbor. So that's our advantage. But how we get that translated into government action is difficult until we have awareness. Once we have awareness, there's no politician that can defend the healthcare supply chain. And that's when I honestly think if you took away this safe harbor, the medical industrial complex would be terminally crippled, because it is so central to everything they do. We want to do a lot of things. We want to chip away nickel and dime, but then we want to keep our eye on the ultimate way to harm this corrupt system, which is consuming 18% of our GDP, and you can't even see a doctor anymore. So thank you for everything you do, Terry, and everyone on the conference call. I have more faith in the grassroots groups. CL alluded to this. I went for years in the wilderness, and the legacy medical groups looked at me like I was crazy. And the grassroots groups have been the single reason why PBMs are on the front page now. And you guys are fantastic. Keep up all the good work.
well, thank you very much. And Dr. Page, I want to close out with you for a little bit. I know COA does an enormous amount of work. I know Rose Gerber. I know a lot of the work that the patient advocacy arm of COA does. And So what are your, and I know it's expanding rapidly. I love getting her newsletters. So what are your thoughts on this? And how do you engage with your patients on any of these issues at all? Or, I mean, obviously your first, or do any of your patients ask you, I guess I should say more importantly, I know that's not what you're going to lead with, but is there any sort of engagement on these like cost issues or access issues?
Yeah, just real quick, and I apologize, you were cutting in and out with your question, but I think I got the gist of it. But just in general, I do a lot of work with COLA, but I also do a lot of work with ASCO, American Society of Clinical Oncology. I'm doing policy and legislative work, and just for 340B real quick, I just want to emphasize. I think a component of that, it should follow the patient. So if you got a disproportionate share, quote, patient that's underserved, it should follow those resources should follow that patient, no matter where their side of delivery of care is. But that requires a law change, which can take many years, as you described. But sometimes we can work on some of those 340B issues, trying to change the rules, such as making changes with ASP 22.5 and that kind of thing. But in general, people have asked me, why do I spend every waking hour that I have just trying to write policy, understand policy, go to Washington, D.C. to try to influence our congressmen and politicians, and go visit the agencies to try to influence the rulemakers and so forth. And I'm telling you, what drives me is it always comes back to the exam room with that doctor-patient relationship. And when I have a patient in front of me that's trusting me with their life with cancer, and I run into external pressures and more rules and laws and legislative activities that interfere what I need to get done for that patient and interfere that doctor-patient relationship. It's when I see those adverse outcomes in my patient, that's what drives me to go back to Washington, D.C. or to Austin, Texas, to try to make differences for my patients. I'm not hearing you, Terry.
I muted myself because you said that, and then I just started speaking. I apologize. Anyway, I wanted to say thank you, Dr. Gray, Dr. Campbell, Dr. Page, for your time today. I really appreciate it. And also Free2Care, Citizen Health, Brandon, David. This is really a great honor to be able to moderate this panel today. And I hope all of you have a fantastic rest of your weekend.
Thank you.
All right. Thank you, Terry. David, would you like to close it out?
I absolutely would. Thank you very much, Brennan. Thanks again to Citizen Health for all that they've done to make this possible. Thank you to all the panelists for the time, the expertise, the passion that you bring to this. And thank you for all that are watching here live and for those that will be viewing at some date to be determined. We're thankful for all of those who are investing their time to learn about these important issues. I am honored to stand shoulder to shoulder with men and women like this is a daunting fight, and we're willing to take it on. The way I approach this coalition is the same way I've managed other organizations. I never have viewed it as a top-down type of organization. Everything that I've ever done is you take that organizational chart and you flip it upside down. The people that we serve are the ones that are in leadership, and for us, it's the patients ultimately. Which means, in the running of this coalition, my job is to be a resource to all of you, to make sure that your organizations, that your efforts are successful. Not so much an umbrella, but a foundation. And whatever needs to be done, whatever needs to be mobilized, whatever issue needs to be addressed, you can reach out to Free2Care, and we will try to find the resources to support you, to uplift you, and to magnify your voice. That's why we exist, as I've said before. Ultimately, again, we want to bring back the doctor-patient relationship. That's the essence. That's actually the basic building block of healthcare. And the reason it's become so inefficient and so expensive is because more and more middlemen have wedged themselves between those two parties. And our interest is to remove that intrusion so that it can be about doctor and patient. Unfortunately, today, we're having to look at the backs of physicians because they've been relegated to data entry clerks, and that's just not what we want for people who are so highly trained. That's not what patients want. So it's very important that we continue this effort, we continue this fight, and it is a fight. And I'm, again, incredibly grateful and thankful that all of you have entrusted your organizations with this coalition and with this effort here today. This has been a great joy for me. So thank you very much for all that you do.
All right. Thank you, David. All right, everyone, I am going to stop recording. Thank you all.
Thank you, guys.